बहुत
But
अल्टरेशन
your
हो
side
गया।
must be good, no? In the mornings, it is warm in
नहीं
the mornings.
नहीं नहीं, इधर गर्म ही है।
Don't forget your evening meeting, JP today.
किस चीज का?
ESRO.
हाँ हाँ हाँ, आज नहीं है मेरा, कल है।
अच्छा, yours is tomorrow, mine is today.
अच्छा अच्छा, ठीक है, जो ज्वाइन करेंगे जरूर जरूर। तो फिर कल तो हॉस्पिटल से ही ज्वाइन कर लेगा।
हाँ, it will be possible, or you can go home also.
बहुत ज्यादा मीटिंग हो रहा है। नहीं नहीं, ठीक है, जरूरी है। आई थिंक अपना बहुत लोग ज्वाइन किया, वेरी गुड।
Hi, Sandeep.
Hi, good morning, sir.
Good morning. How are you?
Good morning. I'm fine.
Good. We meet virtually, staying in the same complex. We meet virtually from different parts of the country.
I have been telling you, sir.
I know.
I know because of the lockdown, but now things have eased out now.
Yeah, but we are
Make
just
a plan.
Yeah. If you make a plan, it will never happen. But
तो
yeah, we will
उधर ही
catch up.
रहता है। संदीप दे बोला ना ये बीच में।
हाँ सर।
तब थाना में रहता है तू भी?
मैं सर हीरानंदन एस्टेट में रहता हूँ, रोडस एनक्लेव।
हीरानंदन एस्टेट में लस्कर के घर के पास वाला?
हाँ, रोडस में फिलिपा। आपका जो मैडम का जो घर है, आप लोगों का जो रेंट पे दिया हुआ था ना, उसके पीछे रोडस एनक्लेव बना हुआ है ना, उसमें।
ओके ओके, तब तो फिर लश्कर के घर से बहुत पास में ही है।
हाँ, वॉकिंग डिस्टेंस है।
इसीलिए तो हम नहीं मिलते हैं।
हाँ, और चिराग के नीचे अंधेरा होता है ना लश्कर। जो चिराग होता है ना, उसके नीचे अंधेरा होता है और सब जगह उजाला है। नहीं, एक दिन एक करो, हीरानंदानी एस्टेट रेडिएशन ऑन्कोलॉजी फोरम करता है, क्या बोलता है?
हीरो, उसका नाम हीरो है, हीरानंदानी एस्टेट रेडोंक फोरम
का एफ नहीं होता है।
अच्छा, एफ बंद करना है, एफ का मीनिंग अलग हो जाता है तो फिर उसको।
अच्छा, तू बदमाश है। अरे आई थिंक गुड आइडिया है। नेक्स्ट दुर्गा पूजा करता है उधर,
करते हैं ना सर?
अरे इधर अच्छा खासा बड़ा पूजा होता है।
हाँ, तो वही तो मैं बोला ना, रैडोंग पूजा करता है उधर।
We'll start on time, no, please.
Sure, ma'am. Hello.
Okay, great.
Yeah, I will log out for some time. I'll join in later on. Chalo, bye. All the best.
Anil, take care. Anil, go ahead.
Sure, sir. Hello, good morning, everyone. So I welcome you all to the second day of our annual meeting of Maharashtra State Chapter of AROI. So we will be starting soon, as our both the chairpersons and the speakers are here. So with your permission, Madam Dr. Sonali. Hello, Dr. Sonali.
Sonali, give permission to start.
Yes, please. Let's start.
Thank you.
Anil, you're not audible.
Oh, no, ma'am. I haven't spoken yet.
With the mask on, I couldn't make out.
We'll be starting with our first session. So I will hand over to my colleague, Dr. Anuj, for just the general rules and regulation, just like the yesterday. So he will take over and then we'll start the session.
Good morning, everyone. So we'll be having our sessions today. The first session will be on GI oncology from 9:15 to 10 a.m. followed by Gynec from 10 to 10:45. 10:45 to 11 we have a pre-break, virtual pre-break, and from 11 to 11:45 we have a session on in uro-oncology, and from 11:45 we have the hematolymphoid session along with the oral presentation of the best posters which were selected yesterday from the e-posters displayed. So the rules and regulations, I would just request all the participants other than the speaker to keep the mic muted during the time of presentation, and there will be a YouTube link and the Zoom link which will be ongoing simultaneously. So any questions which is to be asked to the presenter can be put in the chat box. The comments in the YouTube as well as the Zoom will be seen, and that will be asked to the presenter at the end of his presentation. So we would like to start the session. The first, I will hand over the proceedings to Dr. Sons Paul, and we will start today's session on GI oncology. Thank you.
Hello, a very good morning to all. So we are starting the day 2 of our Maharashtra AROI conference today, starting with the GI oncology today. In the chair, there are Dr. Sandeep De, who is a consultant in Apollo Hospital, Navi Mumbai, and Dr. Rahul Walke is an assistant professor in Nair Hospital. So let's start the session. Over to you, sirs.
Okay, hi, good morning, everybody. Let's start the GI oncology session. So we have two abstracts here. One by Dr. Avina Populwar, and the second one is by Dr. G.V. Priyadashini. And we have our experts in the form of Dr. Reena Engineer and Dr. Ritika Hinduja. So I will call on the speakers who would like to come first.
Shall I start, sir? Yeah. Good morning, everyone. My name is Dr. Abhinav. I am a junior resident at Tata Memorial Hospital. I will be presenting my thesis topic, that is texture analysis as a imaging biomarker of tumor response. In the case, tumor response to chemoradiotherapy in patients of adenocarcinoma of rectum studied with magnetic resonance. So rectal cancer with T3, T4 and node positive disease are managed with the neoadjuvant chemoradiotherapy followed by surgery. And after the surgery, it has been seen that complete responder are 15 to 27%, about 15 to 20% are the progressive disease, and up to 30% have the distant metastasis. As of now, there are markers to predict a long-term outcome, but there is no reliable biomarker to predict a response. Even on the response MRI, to characterize a fibrosis in terms with the viable tumor tissue is very difficult. So we need a reliable objective biomarker which can identify the tumor response. As we have seen, even the complete responder, even after the surgery or not surgery, they have a very good long-term outcome. So if we are able to identify the responder, we can change the treatment paradigm and will provide a platform for more individualized tailored treatment. So for the complete responder, we can go for the wait and watch, and for the poor responder, total neoadjuvant therapy can be given. The intra-tumor heterogeneity is a well-recognized feature of the tumor, which heralds poor prognosis and has shown to be independent predictive marker of disease-free survival. And quantifying this heterogeneity can be used as a prognostic and predictive biomarker. Imaging can potentially capture the information from the entire tumor to assess this heterogeneity in a non-invasive manner. And radiomics is a type of imaging study which can convert the image information to a higher dimension data. A very commonly employed radiomic study is a textural analysis. In textural analysis, each image has a minute area of illumination, that is a pixel, which can represent the gray level intensity, and it has a certain intensity number that can provide a measure to intra-lesional heterogeneity. So it can provide an objective quantitative assessment of the tumor heterogeneity by analyzing the distribution and relationship of this pixel gray level in the image. Now there are 4 approaches to analyze, and out of which statistical approach we have used, which evaluates the gray level frequency distribution by using the intensity pixel intensity histogram, which is a graphical representation of the number of pixels belonging to a particular gray level value in a region of interest. The commonly first order parameters we have calculated are the mean, standard deviation, skewness, kurtosis, which indicate the flatness or the pickedness of the histogram compared to the Gaussian curve, and the entropy, which in layman language describes the busyness of the image. So in our study, we are retrospectively selected a patient with CA rectum, histologically adenocarcinoma, belonging to stage 2, 3, have completed a long course neoadjuvant chemo radiation, and whose pre and post treatment MRI were available at PACS. So their images were imported to the system. The area of interest were defined, and then the texture quantification was done. So each of the previously mentioned first order features were measured and extracted after application of the band filters of various sizes ranging from 2 to 6. These are the special factors. The scale can be considered as a width at which the structure in the image are enhanced and highlighted, while the structure less than width will be blurred. This filter can reduce the background noise if the MRI protocol, MRI imaging protocol is different. So after the neoadjuvant chemo radiotherapy, there were 9 patients who were diagnosed as complete responder, and 91 were partial and non-responder. So we used a manual test to find the who were able to identify this complete responder. And after that, we draw the ROC curve, and we found that the skewness with a filter of 3 was the most significant to find the complete responder with a sensitivity of 55.5% and specificity of 96.7% with the accuracy of 93%. In the same manner, in the post-treatment scan, the mean positive pixel with a filter of 5, the sensitivity was 77.7% and specificity was 92.3%. With the accuracy of 91%, it was able to identify this complete responder. After the surgery, the patients who were having the complete response were again pulled in the initial complete responder group. And again, the TechStat was able to identify on the pre-treatment scan, the patient with the skewness of filter 2 had the sensitivity of 66%, specificity of 73% to identify this complete responder. And on the post-treatment scan, the kurtosis of filter 6 had the sensitivity of 81%, specificity of 46%, and accuracy of 58% to identify the complete responder. Now, when we now there are known parameters for the outcomes, but when we apply the texture analysis to calculate the long-term outcome, it was also able to identify the poor responder and the good responder. Like for the 2-year survival, the patient with the skewness of filter 4 having the cutoff value, having the value above and low of the cutoff value, were having the 2-year overall survival of 97.8% and 80.8% respectively. In the same manner, the disease-free survival, kurtosis and entropy was significant for progressive-free survival, skewness was significant for local recurrence-free survival, mean positive pixel and kurtosis and skewness was significant. Now, when we applied these texture analysis to the known parameters of poor outcome, clinical outcome parameters, we were able to classify the patient into more worse outcome patient and a better outcome patient. Like in our study, we were able to see that the stage 3 disease, the 2-year survival was 91.3%. But the patient with the skewness having the value more than the cutoff were having the 2-year survival of 83.7%. In the same way, the patient who were having persistent EMVI even after the treatment, the overall 2-year survival was 77.4%. But when we applied a TechStat and the patient who were having the skewness above the cutoff value, the 2-year survival decreased to 51.3%. And if the patient didn't have EMVI after the treatment, the overall survival of 2 years was 91.8%, but the patient with the skewness more than the cutoff value were decreased to 85.4%. So to conclude that, we can say that TechStat at present is a very naive and with a very limited data at present. But with the passage of time, we can have a more robust data, which can apply it to the mass population, and we can predict the outcome. So having said that, we can say that the TechStrat is a promising tool to predict a response to neoadjuvant chemoradiotherapy in rectal cancer. It can also predict the outcome above and over the known predictors of the survival, and thereby allowing us to modify and tailor-make the treatment according to the response and prediction. Thank you.
So, thank you, Abhinav, for your presentation. Now we will take the questions after the second presentation. So now I invite Dr. GV to come with her presentation. Dr. GV?
Good morning, sir. I will be sharing my presentation.
Yeah, you start your screen sharing.
Good morning, everyone. I am Dr. GV Monapriyadashni. I work as an associate consultant, clinical associate in HCG Hospitals, Mumbai. But this study is done in Max Hospital, Saket. I just completed my DLB in September 2020. This is on analysis of dose volume relationship and toxicity. This is a single institutional experience in SBRT in liver tumors. Introduction: SBRT is a non-invasive treatment modality for primary and metastatic liver tumors, where curative treatment modality, which is surgery, cannot be applied, or as a bridge to transplant, giving superior local control than other treatment modalities like TACE, TARE, PEI, and RFA. SBRT is a technique that delivers high doses of radiation with hyperfractionation, the advantage being maximizing tumor coverage and reduction of dose to normal tissues, as dose delivered rapidly falls off at the periphery of the target lesions, thereby saving the OARs. Our objective was to present on overall survival, local control, and acute toxicity. And we were able to achieve giving SBRT to both primary and metastatic liver tumors by accurate tumor delineation, motion management techniques, patient immobilization, and image guidance techniques. And inclusion criteria: we took patients with primary and metastatic liver tumors proven by histology or proven with radiology and corroborated vice versa. Exclusion: we excluded patients who had prior radiation to the liver and pregnancy or rumor of child-bearing potential, who had severe medical comorbidities, and who had large volume HCC with normal liver less than 700 cc. We took patients between October 2015 to October 2019. There were totally 50 patients. We did CT simulation with Siemens somatome with 2 mm cuts, and treatment was delivered using Novalis radiosurgery machine. According to the lesion size in the OER, we give a dose of 35 to 54 in 3 to 10 fractions. TG101 was followed for OER constraints. Dosimetry was evaluated from ECLIPSE, and we did response assessment by Embrace's criteria, and toxicity was by CTCAE version 5.0. And observation, we had a total of 50 patients. Males were around 40, and most of them had a PS of 0.1. And we had more of liver mets, 27 as compared to 23 HCC patient. The motion management used, we had most of tumor tracking, it were 24 patients. Next comes the abdominal compression. Then we had a fluoroscopy and a respiratory gating also. And our tumor volume ranged from 6.8 cc to 800 cc. And the liver minus PTV, which is the normal liver, 717 cc to 2700 cc. And dose, the median we gave was around 48 gray, but it ranged from 35 to 54. Respecting the nearby OERs, we tend to reduce the dose if the OER constraints are not achieved. BED median was 85.5 gray, and it ranged from 52 to 151, same respecting the OER constraints. And the 700 cc median was around 9.8 gray. We observed a few toxicities while the patient was on radiation, and after that, during the first follow-up, most were nausea, vomiting, hematological toxicity, and abdominal pain. In this, if we note, only the hematological toxicity was grade 3 and other toxicities were well controlled symptomatically, which was grade 1 and 2. And we did a response assessment, and we found that the dose group BED of more than 40 gray and BED which had more than 71 gray and tumor volume of less than 100 cc were found to be significant only at 3 months, but they were not significant at the further follow-up months. But when we compare if there is any significance between the primary meds and the number of GTVs and the child book, they were not significant. And this is the overall local control of both the primary and metastatic liver tumor patients. We had a median local control of 8 months. 6 months local control came to be around 60%, and 1 year was around 42%. And this is the median overall survival of the both primary and metastatic liver tumor patients. Median overall survival was around 1 year. And this is the separate local control analysis for primary and meds. Those in the red are the primary and those in the blue are the metastatic patients. In this, we found the liver meds had a better control, median local control of 7 months as compared to the primary. The main disadvantage is we had most loss to follow-up in primary HCC. That could be the reason of this. And when we compared with the international literature either has published what we have seen is either on primary liver tumors or as a meds. But because of the heterogeneity of the population, we could not have a separate classification. So we had a combined analysis of for both 50 primary and metastatic liver tumors. And we have given dose to the tumor volume ranging from 6.8 to 800 cc. And our dose range was between 35 to 54, which was almost equivalent to the international literature. And 1 year local control overall ranged from 40 to 50%, which was seen. Ours was around 42%, and the median overall survival in our study was 12 months, which was better than the other studies. And the grade more than or equal to 3 toxicity was only 5% in our study. And the conclusion, we were able to achieve equivalent control rates as compared to the international literature. And SBRT is feasible as a treatment modality for both primary and metastatic, either as a primary treatment or as a bridge to transplant. Limitation and recommendations will be limitations where we had a very small sample size and more of heterogeneous population, and it was a retrospective. We would always recommend a prospective study. Thank you.
Sandeep sir.
Yeah.
Dr. Sandeep sir, can we take questions now?
Yes. I'll just questions.
On YouTube, I can see one question. Shall I read, sir?
Yeah, please continue. Please.
There is a question by Dr. Pramod TK. Question is for Dr. Anubhav. Dr. Abhinav. Did all patients undergo surgery post NACT-RT in case of CA rectum? First presentation.
No, sir. All patients didn't undergo surgery. So the patient who were complete responder and were eligible for the wait and watch, who were able to come for the regular follow-up, they didn't went under surgery. And also the some of the patient defaulted. So total number of surgery were 73, sir.
Okay. Another question is from Dr. Sarbani madam to again Dr. Abhinav. What did the texture features correlate to best in conventional radiology?
What is the texture?
What did the texture features correlate to best in conventional radiology?
You had conventional imaging, right, for your patients?
Yes.
So
yes.
the texture features that you saw, what did it correlate to best on your MRI appearance or your CT scan, whatever it is that you did for your patients? Because all people don't have texture software, right?
Yes, ma'am.
Can you correlate the two?
Ma'am, we didn't correlate with the hyperintensity or hypointensity. Because the MRI itself didn't have high specificity to identify the tumor itself within the fibrosis. So we didn't look for that. We did our own study how we can identify with the texture, and we correlated with the clinical parameter, not with the parameters of the MRI.
But then what is the utility of this kind of analysis if you cannot apply it to the clinics?
We can apply in the clinic, because many of times we can able to identify there is some ulceration or there is some fibrosis in it. So texture can predict with a more objectively, like in MRI, it is a subjective finding, whether there is tumor, whether there is fibrosis or not, but it will give a more objective picture to it and more accuracy to it, man. And also to the clinical finding, it was correlating to the clinical finding, the texture parameters.
I think it will be a good idea, Abhinav, as Dr. Sarbani says, that you must have with the amount of fibrosis. Right now, we don't have that. It's all most of the time it is very subjective finding the response to MRI 2, and the sensitivity is only 40% of the post radiotherapy MRI. So radiologists just report like the partial response or poor response based on the fibrosis present. But there is right now we don't have a software to say even on MRI that what kind of response is there. So it's very subjective, but then it'll be a good idea that we take two radiologists and then see and then correlate with the TexRad. Thanks, Sarbani. Yeah.
And see, Supriya has asked a question: why was hematological toxicity seen when were patients receiving any systemic therapy? I think she wants to mean when patients are not receiving systemic therapy, right, Supriya?
Yes, this is for the second talk, because normally after liver SBRT you shouldn't expect hematotoxicity unless and until liver is compromised.
Good morning, ma'am. Ma'am, we saw hematological toxicities in those patients who had a normal liver of around 1000 cc. Between 700 to 1000 were the people who we saw actually the hematological toxicities, but they were managed. We did not need to hospitalize those patients. So those were the patients we mainly saw.
Were they on any systemic, because you have metastatic patients also, were they receiving any systemic agents or any other medicine or chemotherapy?
Ma'am, during the course of radiation, no. Of course, after that, because they were metastatic, ma'am.
Can I ask a question to Abhinav?
Yeah, Jan.
Yeah, Abhinav, I mean, whatever you did was with only the first order statistics. And we know that, as you had said, texture analysis is based upon so many features, not only the statistical features, but also the modular features, transformation features. So do you have any plan to revisit the idea of looking at shape features, because the texture tool now has this shape features as well as higher order texture features?
So, sir, as of now, for the thesis purpose, I limited it to the first order features only. But yes, there can be many permutation combination which can be used with the textural features and the clinical feature. And I will be looking after that also in future. But as of now, for the thesis purpose, I have limited my study to the first order features only.
I have a question for.
But sir, it may give more information as compared to first order. Definitely, it will increase the sensitivity and specificity.
Can I ask one question, Dr. Abhinav?
Yes, sir.
This biomarker, is it capable of predicting or detecting the early recurrence in cases of C rectum, since one subset of your patients were kept on wait and watch?
Yes, sir. Sir, so we look after it also, and it was able to identify, sir. So for local recurrence, as we know, there are clinical parameters like T stage and the CEA. These are the predictor marker for the local recurrence. So we added the texture features to these clinical parameters, and it was able to segregate the patient itself, who will be the more worse patient and who will be better within them. So as of now, due to the very limited number of patients and very limited number of the events in my study, I have not presented that result in this presentation. But yes, in the cases which got PNI positive, there in them the local recurrence was very high, and the texture analysis was able to identify those patients correctly, sir.
Because I think it will be a helpful tool in specifically in PCR, who patient who has got complete response after this NACTR. Okay, can we take next question?
Yes, sir. I have calculated that, but that is the thing that the number of events over the period of 2 years was very limited. That's why I have not shown that result here. But it has shown to be very, it has shown to identify those patients also, sir.
Okay, thank you. I think there is another question from Dr. JP Agrawal sir for Dr. GV. Gating was used in only one patient. What was the indication?
Sir, that patient was a primary HCC patient, and the tumor volume was large, and he was not willing for this tumor tracking, and he could not hold his breath when we did abdominal compression. So we had other options of advising him respiratory gating. That is why we gave respiratory gating for only one patient.
I think there is another question from Dr. Pramod TK to Dr. Abhinav. How was the sensitivity and specificity of MRI response calculated?
Sir, for the conventional MRI or for the texture feature, sensitivity and specificity?
I think he wants to ask about texture only.
Okay. So, sir, first we applied a Man-Whitney U test to find out which texture parameter correlate with the complete responder. After getting the p-value, we run a receiver operator curve and we got a AUC for that. And with the help of software, we were able to find out a Jordan index, which is the sensitivity plus 1 minus specificity. So whichever parameter have got the highest Jordan index, that cutoff value was identified for the particular textural parameter, and hence we were able to find the sensitivity and specificity for that area under the curve, sir.
Not seeing any other question.
Yeah, Dr. Rahul, then if we don't have any other question, can we ask,
Yes.
move on to the experts?
Yes, sir. Yes, sir.
So on to Dr. Reena and Dr. Ritika for your expert comments.
Yeah. Okay. Ritika, first you can make the comments.
Yes, ma'am. Very nice presentation, Dr. Abhinav and Dr. GV. So, Dr. Abhinav, I think that was an amazing concept. Yes, radiomics is coming up, but I do think, like in CNS, we have some radiological parameters that we can correlate to the radiomics findings, like a T2 flare mismatch, which correlates with IDH mutant. Somewhere, something like that needs to be there in rectum also.
Yes, ma'am. Yes, ma'am. We will be studying
Would
for
be
that
very
as well as.
interesting.
Yes, ma'am. Yes, ma'am. We will be looking after that.
Yeah, we also plan to look with the diffusion weightage imaging also, though like it's still evolving, even the MRI features for that, but still, yeah, we should be looking at that. And
GV, again, very good presentation.
Thank you,
Any
ma'am.
reason, Doctor? So SBRT role, and recently I was reading up a paper last month. It says to sometimes make it resectable also as a bridge to transplant. So in one of the studies I read recently, they said 15% or 20% of patients who are otherwise for only or systemic therapy were actually trans to surgery growth. So SBRT is definitely coming up. Any reason you chose BD of 70 as a cutoff? Because I don't think your median is also 70. So I have
Dr. Ritika, we are unable to hear you.
Your voice is breaking.
Yeah, because
am I audible now?
It's better, slightly better. Please continue.
I was just speaking about liver SBRT now definitely being used as a bridge to transplantive resections where almost 15-20% sometimes go on for only systemic resections. In the present study that they have chosen a VD cutoff of 70. Any reason for that? Because I've read literature for 100. BD cutoff of 100 is to be the one which segregates.
Yes, ma'am. In the literature showed a BED of 100 only, but when we had to categorize the patients, there were more people who were falling below 100. So to have a common distribution, we took a cutoff of 70. We were seeing if we could give at least 90 as a cutoff, but most of the patients we had to reduce the dose considering the OER constraints. We used to decide a radiation dose to the tumor, but if according to the location, whether if it is close to the stomach or the duodenum or the small bowel, if we could not achieve their constraints, we tend to reduce gradually and replan. That is why we had to come down on the dose and as same as the BED. So that's why we decided 70 as the cutoff.
And Reena ma'am and Supriya ma'am, maybe I have a question for you on that note. I was reading some literature wherein humanities in Italy use a dose as high as 75 in 3. Do you think it is feasible? It was a little unimaginable for me.
Ma'am, we didn't. Hello.
So
yeah,
at TMH, typically we don't practice this 3 fraction dose because invariably our tumors are larger because our surgeons are also aggressive and IR people also, they would like to do TACE for those cases. So typically we get very large tumors. So we practice 5 to 6 fractions radiotherapy at TMH. So we don't have experience, but I think 75 in 3 would be a very aggressive dose.
Too much.
Yeah.
What I have seen at Ottawa during my fellowship is either 54 in 3, very localized, centralized liver tumor, which is small, or 48 or 42 in 6 was what we would practice. But 75 in 3, I really wanted your opinion. I thought it is.
Yeah, and many people will proceed on to. So, Dr. Chiva, how many patients did they have liver failure or within 3 months of completing SBRT? Because that's a very common thing what we see after SBRT. And then they have to, yeah.
There were some patients who had a failure, but I don't know the exact number. I'm very sorry for that.
Yeah, the liver failure. Yeah, the liver toxicities.
Ma'am, there were few, but I don't remember the exact figure. I'm so sorry for that.
It's okay. Supriya, you want to comment?
Just want to make a comment that as all of us know that choice of dose is multifactorial. So highest people have gone is 16.3, but and BED 100 is more applicable for metastasis because HCC is a much more radiosensitive tumor. So if you can reach 85, 86 BED, that is also acceptable. And there is no otherwise hard and fast rule because it's all depends on location, where the tumor is placed, size of the tumor, background liver parenchyma. What we missed in this presentation today is the BCLC class and child score of these patients, which can have a very major impact on outcomes because relapse rates or progression, how you've classified, seems to have a smaller duration. But again, M-RECIST can sometimes confuse.
Yeah.
Anything more there to add, Dr. Reena, or we will conclude the session if there is no other question?
Okay, I think you can conclude. Yeah.
Okay. Thank you, everybody. Excellent presentations, both the presenters. So we'll conclude this session.
I would say thank you to Maharashtra State Chapter AROI organizers. Thank you, Dr. Vyas sir. Thank you, Dr. Pingle madam and Dr. Anil. I would like to appreciate great efforts by Dr. Anil, Dr. Anuj and team to organize and conduct this wonderful conference. And nice presentation by Dr. Abhinav and Dr. GV. All the very best. I think we can go ahead and conclude the session. Dr. Anil, over to you.
Thank you, Dr. Sandeep and Dr. Rahul for chairing the session, and also to Ritika ma'am, Reena ma'am, and Supriya ma'am for giving their expert comments on the GI oncology session. So now since we are concluding the GI session here, and we are moving on to the gynae session. I invite Dr. Manish Chandra, Head Radiation Oncology Department of Jupiter Hospital, Thane, to chair the gynae session. Also, Dr. Sumit Basu from Alexis Hospital, Nagpur, to chair the session. I think Ruby Hospital, Pune. Sorry, Dr. Sumit Basu from Ruby Hospital, Pune, to chair the session.
Thank you. Is Manish there? Hello?
Can't see
Hello.
him. Go ahead.
Yeah,
Hello.
so...
yeah, hi Sumit.
Hi, Manish. Hi. I'm traveling. I'm in a train, actually.
Okay.
Yeah.
So that is the advantage.
Yeah, fortunately network is there, so we can continue. Yeah, okay, great. So, Manish, go ahead.
Yeah. So I think we have to invite the speaker first. So the first speaker is Dr. Amrendra Kumar. And he would be talking about effect of pre-treatment hematological parameters indices in the disease-free and overall survival in cervical cancer patients treated with radical chemoradiotherapy. Amrendra. So is Amrendra there logged in? So train is quite quiet, Sumit?
No, I'm in a coupe.
Okay,
I'm in a coupe, luckily,
there is no background
and
noise.
using the headphone. No, headphone, I'm using the earphone. Yeah.
Okay.
But fortunately, network is there. So I'm very close to Bilaspur right now. Okay. Yeah, it's there. Yeah. Okay.
Good morning, everyone. So the topic of my presentation is correlation of hematological parameters.
Relax. दिला असता तर ती तत्ताळात बाहेर आली नसती. सलील सोड.
So cervical cancer, around 5.7 lakh cases were reported in 2018, and it is the most common gynecological malignancy. The fourth most common cancer in the women, ranks second in terms of mortality. Most common cancer in 28 countries and leading cause of death in 42 countries. The incidence in India alone in 2015 was 96,922, and India remains to be the biggest contributor in terms of mortality, followed by China. So coming to background. Cancer-mediated induction of pro-inflammatory cytokines and immunosuppressive factors induces immune hematological parameters. And there are recent emerging evidences which support that these systemic indices of immune inflammation can act as independent prognostic factors for various solid cancers, including cervical cancer. So to investigate the clinical implications of these with the clinical outcomes in locally advanced cervical cancers, this retrospective study was done. So we can see that there are multiple studies which have been done in the past. However, in these studies, the treatment protocol that have been followed in locally advanced cervical cancers are not uniform, and they are not in concordance with the current treatment guidelines. However, in the studies where the treatment protocol was followed, the number of patients are very less, as we can see. And also they have not studied lymphocyte monocyte ratio and prognostic nutrition index, which are important prognostic markers. So we started this study with the aim to investigate the clinical prognostic implications of pre-treatment and weekly changes in the hematological markers of inflammation, and to study their impact on overall survival and disease-free survival in cervical cancer patients who are treated with chemoradiotherapy followed by brachytherapy. So between 2003 to 2017, we included 1,330 advanced stage cervical cancer patients amongst those who have received RT alone were removed, and we have come with the data of around 1,051 cervical cancer patients. So all the clinical parameters, age, stage, histological type, and hematological parameters were taken from the EMR, and the indices, which included neutrophil lymphocyte ratio, platelet lymphocyte ratio, lymphocyte monocyte ratio, and prognostic neutrophil index were taken. The PNI was defined as 10 multiplied by albumin concentration plus 0.005 into total leukocyte count. On the basis of number of chemocycles received, two groups were made, one which received less than 5 cycles and another which received 5th and the 6th cycle. And a univariate and multivariate analysis was run to evaluate these factors with DFS and OS. So coming to the descriptive statistics, this was the median age of our study group was 50 years. And the stage-wise distribution, the 2B were the most, which included 49% of the patients, and 3B included 37%. Amongst these patients, 130 patients were treated with IMRT technique, and the remaining were treated with Boxfield technique, which was either cobalt 60 gamma rays or conventional 3D CRT X-rays. And 11% patients were given interstitial brachytherapy, and remaining 89% were given intracavitary brachytherapy. So this is the curve. This is the Kaplan-Meier for the survival, overall survival, and the disease survival. The median follow-up seen was 91 months in the live patients. At the median follow-up, 64.7% patients were alive and 59.7% were disease-free. So these are the pattern of failure. The distant failure in 130 patients, distant failure was seen. Local only was seen in 57 patients. Loco-regional was seen in 32 patients. Second primary and distant failure was seen in 5 patients. Loco-regional and distant was seen in 12 patients. And regional and distant was seen in 16 patients. So on univariate analysis, we concluded that advanced stages, other than the squamous histology, lower hemoglobin count, platelet count, PNI, NLR, and PLR were significant for overall survival. And for disease-free survival, lower hemoglobin count, lower platelet counts, higher platelet counts, lower PNI, and lower LMR were associated with poor DFS. So we also saw the trend of fall in the LMR from the start, that is baseline, which was taken 1 week before the starting of treatment and at the end. So we saw that the median fall in LMR was 3.26, and the patients who had a fall of more than 3.26, they were associated with poor survival, and the trend was seen also in disease-free survival. Coming to the multivariate analysis, stage, histology again, and the PNI and LMR were significantly associated with the overall survival. And on disease-free survival, stage, histology, PNI, and LMR was associated with poor disease-free survival. So coming to the conclusions, high LMR and PNI at baseline had significantly better overall and disease-free survival. Patients with higher pretreatment PLR had poor overall survival. The patients having low hemoglobin, high platelet count, high PLR, and falling trend of LMR are associated with poor OS and DFS on univariate analysis. There was no effect of age and pre-treatment NLR on the treatment outcomes, as was seen in the previous studies. And we need further research to get more insights, and clinical relevance is warranted. Thank you.
Okay. Yeah. Okay. So I think we'll straight away call the next speaker, Dr. Nilesh Ranjan, to speak on his topic. Himself. Yeah.
So Nilesh will be talking about developing new methodology for late toxicity reporting in gynecological radiotherapy trials.
Hello, good morning everyone. I am Nilesh, third year junior resident in Tata Memorial Hospital. I am going to present my thesis. The topic of my thesis is developing a new methodology for late toxicity reporting in chemoradiation trials in cervical cancer, which we acronymed as MOSES, standing for Merns and Severity Score. So why we need to actually develop a new scoring system? Just in brief, going into the background. So we know for any clinical trial or we report toxicity either in the form of physician reported or we are patient reported toxicities. Physician reported toxicity has been standardized and we follow CTCAE. NCI developed CTCAE for toxicity reporting, and similarly for patient reported outcome we have different set of questionnaires. But at the end of trial, when we summarize the toxicity of a patient, we often report as the worst score that the patient had in a particular organ system. Suppose a patient at 6 months of 9 and 12 months of follow-up had a grade 1, 2 and 3 diarrhea, then we report that patient as a grade 3 and we ignore other grades like grade 1 and grade 2, that is the lower grade of toxicity. Similarly, when we do a maximum grade method, we often also ignore the duration the patient has spent in other grades of toxicity, or for that matter, even in that grade of toxicity. We just get a cross-sectional picture of that particular single grade. So also, over the years, multiple studies have been done which showed that there is definite discordance between the patient-reported outcome and the physician reporting of toxicities, which has been established well by the NRG 1203 trial, which clearly showed that there is need to incorporate patient-reported outcome into the survival outcomes also. So this is not something new which we have tried. There have been multiple attempts to modify this toxicity summarizing in literature. We have Trotti group which actually tried a TAME method in head neck cancers, which was actually found to be not very much effective for late toxicity and limited to acute toxicity. Similarly, Thangasirajan group with applied this Toxty method for 2 alliance trials, but it again was so complex statistical calculations were there, so not easy and feasible to apply. And in IMBRES patients, lepers is something which is coming up in gynecological malignancies, which has this shortcoming of just categorizing patients into 2 groups. So what we need to understand through this curve, which is actually a work from our my senior Dr. Jagdish in his thesis, which is actually showing the pattern, how the patient has evolved. There were 90 patients actually with rectal proctitis. So what we have seen that we can't label any patient as a grade 3 or grade 2 because the patient spent a long time over in any grade of toxicity. So we want to through this curve we just want to say that it's not a single point picture to the toxicity. It's something which evolves over time that we need to understand. On this background, we have actually hypothesized that if we give a time-weighted CTCA score, would be a better correlation with substantial changes in quality of life than the CTCA maximum grade method. That is our conventional way of reporting toxicity. So what we took patients from a phase 3 randomized control trial, that is the PARSER trial comparing 3DCRT versus IMRT of our center only. So from there we actually taken patients, and among those patients we actually included those patients who were symptomatic for toxicity either on the physician based CTCA or patient reported outcome. And the patient must have at least 12 months of follow-up and at least 3 QL scores should be available. We excluded those patients who do not report any patient reported outcome. So this is the trial schema, that PARSER trial, which from which we have taken patients. So there are 300 patients randomized into 3D-STAT and MRT arm, and the follow-up schedule which we followed at that for 2 years, with every 3 months we took that QL data and the CTC grading, and then 6 monthly over 2 to 5 years. And this is the flow diagram for my thesis. Out of these 300 patients, 201 patients were eligible and included for analysis. These 200 patients, again, I would say that they are those patients who have reported either the toxicity on physician-based maximum that CTCA, or they have reported one of the scores more than 1 in quality of life reporting. So we have shortlisted actually 6 toxicities. Now these 6 toxicities which we included for analysis, like diarrhea, anorexia, pain, urinary incontinence, frequency, and fatigue, based on the fact that all these have a corresponding questions in the quality of life questionnaire. So we can see in the brackets like number of patients. So the total number of patients is coming more than 201 because many of the patients has overlapping toxicities. So what we did, we collected the data of toxicity through this QLQ-C30, Avix 24 and the CTCA grading. And then we calculated a time weighted score for these patients. And then we actually correlated that with quality of life data. So these are the steps of assessment that we are coming like in for the next few slides. So we have selected 6 symptoms and then we calculated this Moses score. And we did an ROC analysis to find a cutoff for this Moses score, which can predict the substantial deterioration in quality of life. So we got a cutoff of 0.20 for all these symptoms. Also, we dichotomized the CTCA maximum grade as grade 0 and 1 as low grade and grade 2 to 4 as high grade. And then we perform a chi-square to find the diagnostic ability of this Moses against CTCA. So we should know how to calculate this Moses. So for that method, we actually give 2 scores to the patients. One is called proportional score and other is called severity score. So by example, I can like explain this. So suppose there are 2 patients, patient A and patient B. So patient A had like grade 3 at 6 and 0, and then subsequently the CTCA grades at for 24 months of follow-up. And this is similarly for patient B for 84 months of follow-up. So the first step in the calculation of Moses score is to calculate the total length of follow-up. So for this patient, it is 24 months, and for patient B is 84 months. Then next step is to calculate the proportional score. Now proportionate score is actually defined for each of the grades, and it is something which is defined as a number of months that patients spent in a particular grade of toxicity upon total follow-up months. So for example, in grade 0, patient has spent 3 months out of this 24 months. So that proportional score will come as 3 by 24. Similarly, the patient in grade 3 has spent 1, 2, 3, 4, 5, that is 15 months. So the proportionate score for grade 3 will be 15 out of 24 months. So similarly, we calculate for all grades and then we multiply that with a severity score. Now, the severity score is actually the grade of the toxicity. So suppose if the patient has grade 1, then that will be scored as 1, grade 3 will be scored as 3. So then we multiply these 2 scores and we get a Moses score for each of the patients. So when we look the CTCA maximum grade as per maximum grade methodology, we'll see that both the patients are actually grade 3 patients. But when we see the Moses score, in patient A, we got a score of 2.13 and in patient B, we got a score of 0.23, which is almost a 10-fold difference. So we can't say that both the patients are similar in terms of their toxicity. So next step was to evaluate the QL. So QL has also, the way we analyze QL conventionally is we actually take a point based analysis, like before after analysis. We take a baseline QL score and then we actually find the difference with the worst ever QL, or we define a fixed interval that we will see the difference in the QL at 24 months and 12 months. That again a single point picture. We don't want to analyze that. So what we use for QL analysis is something which is defined as substantial change in quality of life. So we calculated the total number of quality of life patient has like filled the data, and if the patient has spent more than 50% of the follow-up duration in with a score they have given more than 1, then that is something which is called as substantial quality of life change. Otherwise, if it's less than 50% duration spent in a poor QL, then that is an insignificant change. We also analyze with a conventional method of this QL difference, that is baseline and the worst, and we see the correlation between the two. Now, when we see the correlation, for example, we started with diarrhea actually. So this is a hit plot which actually showing the QL data over the subsequent follow-ups and the CTC data, and this Moses score and the maximum grade score. So what we found that out of 80 patients we analyzed for diarrhea, 55 had grade 0. These patients are grade 0 on physician-based reporting, but they are actually given some score on the quality of life questionnaires. But there are 17 patients who have been labeled as grade 1 on physician, similarly 4 and 4 for 2 and 3. So when we calculated the Moses score, so for grade 1 patients, it ranges from 0.04 to 0.32, and for 2 and 3, these are the ranges and these are the mean scores. When we see this box whisker plot, we find that the grade 2 and grade 3 patients are somewhat overlapping. So we, as per CTCA, they might be different, but when we see through the Moses score, these are not very different patients. So then we tested for the diagnostic accuracy of this patient, considering the quality of life change as the gold standard. We found that both CTCA in Moses are almost similar in accuracy, and both are significantly correlating with substantial fall in quality of life. But when we see all other symptoms also, like all these 6, we found that Moses was able to predict quality of life better in diarrhea, abdominal pain, urinary incontinence, and fatigue. But the CTCA was significantly correlating only with diarrhea and abdominal pain. And when we look for diagnostic accuracy, we'll find that in all symptoms, either Moses is equivalent or much better than CTCA. So after this individual symptom scale correlation, we did a cumulative symptom burden. Now, cumulative symptom burden, we actually summed up all the scores of Moses and find a final Moses score. And then we correlated with role functioning, global quality of life, and then physical functioning. So what we found that for role functioning, both of them were equivalent, but physical functioning and global quality of life, that Moses was found to predict much better than CTCA. So with this result, I want to conclude by saying that the time imputed toxicity scoring actually correlates better with quality of life symptom item, and cumulative toxicity burden using Moses provides a good correlation with functional scales. Thank you.
Okay, thank you, Dr. Nilesh. So we'll call upon the third speaker for the session, Dr. Pradnya Chopde, to talk about her thesis or whatever she's presenting. I don't have the details right now.
Evaluation of serial bone density changes in the woman undergoing pelvic radiation for early CA cervix.
My screen is visible?
It is visible.
Pradnya, you are not audible. If you have muted yourself, kindly unmute.
Hello?
Pradnya, a little more loud. We can just hear a faint voice.
Can you hear me?
Little more loud. Use the computer audio if you have a system audio rather than the headphone.
Can you hear me now?
It's very faint.
Hello?
Hello. Pradnya, we can hear you, but it's very faint.
So, is it better now?
Yeah, slightly better.
Volume. Yes, sir.
Use the system audio if you
cannot
have.
hear you, Pradnya. It is not clear to everybody.
Is it audible now?
Yeah, more or less. I think you just be a little louder and just go ahead, I think.
Yes, sir. Good morning, everyone. I'll be presenting my topic, which is serial evaluation of serial bone density changes in women undergoing chemoradiotherapy for early cervical cancer. So we know that osteoporosis and osteopenia is common in postmenopausal women, and that the pelvic radiotherapy for gynecological cancers delivers a substantial dose to the lumbar and pelvic bones. The pelvic radiotherapy portals for postoperative cervical cancer patients cranially begins from the L4-L5 junction or the bifurcation of common iliac vessels, and cranially caudally goes up to 2 to 3 centimeters below the obturator foramen, irradiating more or less the whole of pelvis. Pelvic insufficiency fractures and avascular necrosis are known complications of pelvic radiotherapy. However, the rate of bone density loss as a function of radiation dose and time has not been systematically investigated. These are some of the examples of the pelvic bone events that are seen after pelvic radiotherapy. We can see an insufficiency fracture of the sacrum and avascular necrosis of the head of femur and acetabulum. It is recommended that we limit the femoral head doses to less than 50 gray. In an IMRT plan, we plan to achieve the D mean to between 12 to 13 gray and remit the V15 to less than 30% and V30 to less than 15%. The standard investigations for measuring the bone mineral density is a dual energy X-ray absorptiometry, that is the DEXA scan. However, there are various other validated measures for bone mineral density measurement, that is the conventional radiographs, a DEXA scan, a technetium 99 MDP bone scan, an MRI of the pelvis, a quantitative CT, and a multi-detector CT, that is the diagnostic CT scan. Now, in a high volume center like ours, the baseline and a follow-up CT scan that is done can serve as a surrogate for investigating the bone mineral density loss. This is a paper by Zaidi et al., where they correlated the Hounsfield units, the CT-based Hounsfield units, with osteoporosis, osteopenia, where they gave the values of Hounsfield unit of less than 110 correlating with osteoporosis, between 110 to 130 correlating with osteopenia, and more than 130 correlating with a normal bone health. So we hypothesized that there is a relationship between bone mineral density loss and an absolute radiation dose received, and that the lapsed overall observation time, and that it can be studied as a function of time and dose and the interaction between these two factors. Now, the inclusion criteria were patients who received postoperative pelvic radiotherapy within a prospective clinical trial of adjuvant chemoradiation, and that there is an availability of postoperative post-radiotherapy axial CT scans at 2 distinct time points spanning at least 12 months apart, which was a trial protocol itself. The exclusion criteria were patients who had received re-radiation, any of the patients who are already having a pre-existing fracture or bony or muscular disorders, or having any metallic implants placed in the hip, and any patient who were previously on bisphosphonates or any form of hormonal replacement therapy as per the records. We screened 300 patients from the database of a phase 3 randomized controlled trial of postoperative radiotherapy, and we excluded 168 patients and included 132 patients who had serial bone density serial scans at an interval of 12 months at least. Now, 13% of our patients had their scans done between first 12 months. 47% of the patients had their scans done between the 13 months to 24 years, that is the second year. 22% patients had their scans done between 25 to 36 months. 10 patients between up to 48 months, and only 8 patients had their scans done beyond 49 months. These follow-up months were further categorized into 0 to 12, 12 to 24, and 36 and beyond. These bony points were assessed on the baseline scans for bone density as well as the doses that were received. The points that were taken, these bones were categorized into upper lumbar vertebrae, mid lumbar vertebrae, and the lower lumbar vertebrae. The upper lumbar vertebrae were taken as L1, L2, mid lumbar as L3, and the lower lumbar were categorized as L4, L5. 25 points were taken on each vertebrae, longitudinally as well as axially. So the first point over the lumbar vertebra was taken at the first section here, and it was placed at the anterior point. Second was placed here at the left end corner, third at the posterior end, fourth at the right side, and fifth in the center of the vertebral body. These points were again repeated longitudinally along the vertebral body as 1 to 5 over here, 6 to 10, 11 to 15, 16 to 20, and 21 to 25. Along with these, we took 2 points each on the pubic symphysis, anterior superior iliac spine, head of femur, and greater trochanter. These same bony points were reassessed on the follow-up CT scans for the Hounsfield units. This is a pictorial depiction of where we measured the pubic points and the pubic symphysis and on the head of femur. Now, the data was horizontally organized from baseline to the final follow-up CT scans, and it was later vertically organized to measure the Hounsfield unit loss. Now, each data was later rearranged to measure the Hounsfield unit loss at different time points between the ages that we between the time periods that we categorized. This is a depiction of how the data was captured. We saw that this is an example at the L5 vertebrae, and we saw that the median Hounsfield unit loss at the L5 vertebra was approximately 55 Hounsfield units, which was seen at a median dose of 48 gray. At L4 vertebrae, the median dose delivered was 30 gray, and the median Hounsfield unit that we saw was 35 Hounsfield units. And at L1, L2, the median dose was 2 gray, and the median Hounsfield unit loss was 15 HUs. We correlated the radiotherapy dose and the Hounsfield unit with a bivariate analysis, and we found that as the dose increased linearly, there was an increase in the Hounsfield unit loss. This was at the L5 lumbar vertebra, which correlated 50 to 60 Hounsfield units correlated with a significant Hounsfield unit loss. This same very analysis was done with the Hounsfield unit loss and the follow-up duration in months. And we found a similar correlation, a linear correlation between the duration and the Hounsfield unit loss. The second thing that we also analyzed was the proportion of patients who were osteoporotic, osteopenic, and with a normal bone health before and after pelvic radiotherapy, taking the cutoffs as 110 for less than 110 for osteoporosis, 110 to 130 for osteopenia, and more than 130 as the normal bone health. To begin with, at the upper lumbar vertebra, we had 98 patients who had normal bone health. Only 24 were osteopenic and 5 were osteoporotic. However, at the last follow-up, 27 patients were with a normal bone health, 52 were osteopenic, and 47 were osteoporotic now. In the mid lumbar vertebrae, 80 normal and 39 had osteopenia to begin with, and 5 were osteoporotic. At the last follow-up, 32 had normal bone health, 37 became osteopenic, and 63 became osteoporotic. This was further exaggerated at the lower lumbar vertebra, where we saw 112 patients becoming osteoporotic and 17 becoming osteopenic. Only 3 patients had normal bone health. These are the preliminary examination findings analysis that we've done. What we know for sure is that the loss of an average of 50 Hounsfield unit is seen at 45 to 50 gray with a linear dose-response relationship, which is best studied at the lower lumbar vertebrae. However, we are still correlating the loss of Hounsfield unit over time and the interaction of dose and time with a linear mixed model. Also, we are evaluating the impact of other factors using the univariate and multivariate analysis. And we are also trying to establish a thumb rule of per 5 gray loss of Hounsfield unit corresponding with 5 gray each to develop a recommendation for a dose constraint. And what we know for sure is that there is a need of routine monitoring of bone health and interventions accordingly, appropriately. Thank you.
Okay, thank you very much. Yeah, Manish, you want to take it?
No, you can continue.
Yeah, thanks, Pradnya. Thanks to all the 3 speakers. Haven't seen any questions coming up. Are there any questions from the audience? From the people present? If there are no questions, I just want to ask you, Pradnya. So, see, I mean, we have the constraints we know, but I still haven't understood really, I mean, what was the significance of this study? I mean, are we going to change the constraints, or what is it basically that we are really looking for? I mean, from the clinical point of view, exactly. I mean,
so we are planning to come up with a correlation of per gray correlating with a Hounsfield unit loss, and then if we know that, maybe we can come up with a dose constraint to be kept at L4, L5 junction or at the lower L5 vertebral body at least, so that we can preserve the bone.
Yeah, because mostly we look at only the pelvic, I mean the femoral heads is what we look at.
Yes, sir.
So you're talking about, including these and then look at the bone health. Yeah.
And especially when we know that these are the weight-bearing bones.
Yes.
So, Pradnya, I would like to know, like, the commonest site of insufficiency fracture is actually the sacral ala.
Yes, ma'am.
Followed by maybe then the L5 is commonly affected, probably. So,
yes, ma'am.
Now the pictures that you showed there were specifically for L5, L4 commonly.
I think
Yes,
they have not verified the other bones, but she has emphasized on L5. But the same kind of bone loss will be observed if we see other pelvic bones also.
Yes.
Yeah.
Yes.
But Pradnya, is there any plan of giving a different dose constraint to L5?
So we're trying to come up with the correlation with each 5 gray dose delivered, and with that maybe we can give a constraint for L5 or at L4.
Because you know the kind of planning that we do, if we are doing a IMRT based planning and trying to give a constraint to L5, which position, if we do a serial IGRT, we see it very clearly that position changes a lot.
Yes, sir.
So constraint giving, it would be very, very difficult to do it without image guidance in these cases. If we
Yes,
give
sir.
a constraint.
Can.
Any other questions? But it was a well-designed study. I think we may not see the use right now, but at a later date, it might be a very useful one.
Yes, sir.
Yeah, absolutely, I agree. So I think we'll ask our experts to give their expertise, and we have experts, Dr. Chandni Hotwani and Dr. Lavanya Guram. So I think we'll hand over to the experts to take the session further.
I think it was a nice presentation by all the three speakers. For the one talking about the hematological parameters, Nilesh, I think it was Nilesh.
It was Amrendra.
It was Amrendra Kumar.
Amrendra.
It was Amrendra. Yeah.
So I just wanted to know what would be the effect if at all those patients had received some kind of neoadjuvant chemotherapy followed by for chemoradiation. So any correlation with the change in parameters to the local control and the survival?
So in the previous studies where the was given for treatment, NLR was significant prognostic indicator, ma'am. But in ours, the NHT was not given, so NLR NLR was not significant with the OS and the DFS.
Amrendra, can I ask with the permission of chair?
Sure.
Amrendra, so you can differentiate those who are going to live long, those who are not going to live so long. Right, Amrendra?
Probably yes, sir.
Okay. So do you propose a change in the follow-up? See, by the time you complete, you are getting a hint that they are going to live for longer time.
Yes, sir.
So, see, one of the weakest link in the whole evidence-based medicine is the need of a follow-up. Okay?
Yes, sir.
So, can you propose on the basis of this a hypothesis that these patients needs to be followed up loosely, or these patient needs to be followed up tightly, in the sense that you want to aggressively pursue for their imaging, etc., etc.?
Sir, you have made excellent point actually, sir. Because what I had seen in my study, as the duration was increasing,
Amen.
number of events which were happening in the adverse factor group, they were higher as compared to those in the favorable. So, sir, yes, a change in follow-up will, a change in the schema follow-up will help, sir.
Or adjuvant treatment can be offered to some group of patients
तो एक काम करना उनको एक
who are likely
एंटीबायोटिक और
to
एंटी इन्फ्लेमेटरी
fail.
दे करके एक वीक के
Do you
बाद
think
मिलने
we can propose those hypotheses?
Sir, maybe down the line, yes, sir, maybe.
Okay. So because to do after 1,000 patients and you say insights and large studies, for me has no meaning. So you cannot have more than 1,000 patients in any group of studies. Okay. So you have to come out with a very clear, succinct conclusions specifically on the strategies you are going to use for helping the other patients.
Okay, sir.
No, that's my suggestion. Okay.
Good morning, all. Lavanya here. I think all the three studies that were presented today from gynec are very important studies in the future to come. And all the three studies have systematically evaluated the questions. I would like to commend the students, especially because they have put in a lot of hard work for this. And also, I think these will have implications in the years to come. And definitely there is some more work to go in before conclusions. If anyone from the audience have doubts or any inputs, you're welcome.
So
I think
so yeah, Manish, go ahead. Yeah, it's okay. Yeah.
So if there is no doubt, I think we can close the session. But at the end of it, I would like to say all three of them are very good studies, and all three of them has a potential to turn out to be something bigger in the years to come.
Sir, there is a question from Dr. Omkar Zopate to Pratnya's study, I think, regarding the baseline vitamin D and calcium level and supplements. Were they traced or not?
So these tests, they were analyzed as per the EMR records. Only 10% or 15% of patients gave the history that they were initially on calcium vitamin D supplementations. Not all were on vitamin D supplementations.
I think that I would agree with it, and that correlates with our average follow-up data. If we see on a very loose note, very few of them actually persist and continue their calcium supplement even if they prescribe. So this is what I have noticed personally in my follow-up data also. So that's true. Even if it is prescribed, how many of them take actually is a big question mark.
Can I make a comment?
Yeah, sure. Please go ahead.
Tell me.
Sons, can I make? So I think the reason we did this was very rightly somebody is selling mungfali.
I think so. Sumit is there.
So let me just come. So the reason this study was done is because if we look into breast cancer, women who go on hormone therapy, bisphosphonates is a very routine prescription that is added when women go on hormone therapy. And sadly, so world over, nobody addresses bone health of women who have gynecological cancer. So I think there is clear implication, as it has been pointed out, on vitamin D, calcium, but also to have future studies which test bisphosphonates or any other strategies for these patients. And as far as dose recommendations are being discussed, they may be very difficult to implement in the region that it is needed, because you give high dose there. So I think all this will be more theoretical, that okay, keep dose below a certain level, but much more practical would be other strategies to improve bone health.
Yeah, I think I would totally agree, Supriya.
Absolutely.
Because constraining the dose at L5 is practically not possible. Whatever we say in theory is different, but practically not possible. So curtail a dose at L5. But other strategies like bisphosphonate or calcium supplement, another thing we follow very regularly. But as I told you, the compliance is a big issue. Even though we advise, there are very few patients, they have their own myths about calcium tablets and constipations.
And other thing is that we have shown today only L5, but there is a dose gradient between L2 to L3. So probably controlling dose at higher vertebra will be much easier. Some bones will be controlled, others will not be.
Supriya, anything, have you included the extended field also in this data or not?
No, to actually keep the cohort homogeneous, because there's an impact of menopause also, age also, pelvic field also. So we had this very uniform cohort, but we have to test this in other patients. We will do that stepwise.
So why don't we plan a more prospective study on this thing?
Yeah, future students. Yes.
Yeah.
Also,
I think on that, yeah.
There is a question from JP sir regarding Pratnya's study regarding the clinical implications of osteopenic and osteoporotic events with respect to age or weight of the patient.
So we've seen that patients who were osteopenic and osteoporotic at the last follow-up as well, we actually have seen that higher age women, like women who are postmenopausal or women more than 48, 49 years of age, are showing a higher bone density loss. But we are yet to complete our univariate and multivariate analysis. So maybe we'll be able to comment better after that.
Pradnya, the issue here is you are giving a pelvic radiation, so you are creating a menopause technically, right?
Yes, sir.
Post-surgical
these are
patients.
All would have undergone surgical
sir.
menopause, no? Pratna?
No,
You've
no,
taken
no.
early
So,
cervical cancer patient.
so what I'm trying to understand is a simple thing. Since we are going to talk on the basis of patients who are undergoing pelvic radiation and the implications for the dose constrained business, right? So that was the basic question to start with, that what dose constraint may be given. Am I right?
Yes, sir.
Am I right? Or
Yes,
have
sir.
I missed something?
I think, sir, Dr. Supriya just emphasized that it is not the dose constraint where they are looking at. What they were looking more at the strategies to prevent osteoporosis or osteopenia. Dose constraint, they are just trying to think a thumb rule kind of thing, that with every 5 gray dose, what is the decrease in the Hounsfield unit?
So then technically each woman, irrespective in Indian scenario, is osteopenic because or in a postmenopausal status or whatever, because they don't have a nutrition.
Sir, they are osteopenic, but by adding radiation, we are increasing or hastening the process of osteopenia or osteoporosis.
So as such, any radiation to the pelvis, you start calcium supplements, or
Yes, sir.
this may become like a pre-audit rule that any pelvic irradiation will have supplements of calcium and osteophos for 2 years.
Sir, we are living in an evidence-based medicine era. Someone has to provide the evidence for it.
So pelvic irradiation, menopause.
Pradnya and Supriya, they are good
No.
job of providing the evidence.
No, but we
for
will
a
just add
well-known
looking.
thing.
We will add all this just based on this data, because it will be unethical to actually do a randomized trial.
So I think they are adding to the evidence, and if evidence is there, we are all more comfortable.
No.
It is just not what I say or what you say.
No. See, basic idea is, even if you say they are osteopenic, like a general population, what are the clinical implications? That's what I'm saying. Fracture or poor bone health means what?
Sir, backache is a very common problem when the patient come to us in OPD. In the follow-up, backache is one of the very major common problem in most of our patients.
If you go back in the history across in any portal or any gynecological OPD and OBS OPD, that is a common issue. So has it enhanced?
But sir, just because it is a common issue, we cannot ignore it.
That's what I'm trying to say. So there may be the other issues which are more pertinent, like in Moses. Don't forget Jesus and Moses. They were two brothers. And pain. No, I'm not joking. It is very serious business. Okay, good. At least you enjoyed. Everybody enjoyed this Sunday one.
Yeah, absolutely. I think on that note, I think if there are no further, there was a question from Dr. Jayant, I suppose.
There is one more question to Dr. Amarendra from Jayant, sir.
Dr. Jayant, Dr. Jayant,
have you taken any history of Ayurvedic medication as hematological parameter to correlate with the hematological parameter, as they are sensitive to Ayurvedic or any other medicines? Amarendra?
It is a typical James bouncer.
Sir, no, sir. The history of Ayurvedic medications or transfusions were not available on the EMR, hence they could not be recorded, sir. And you are right, sir. It will make us. It will have effect on the hematological parameters for sure.
Yeah.
It's because
it's a retrospective, right? So you will not have most.
It was retrospective.
Jens, you would like to make a point?
It's okay if he has not taken, then it's not taken. But this is a very important and a pertinent question, because most of our patients have taken something, some sort of a medication, like homeopathic medications, Ayurvedic, and some patients even take steroids before they come to us. And these hematological parameters are very sensitive to these medications, especially when you have taken steroids. So it may not be a representative one. That's what I was trying to highlight on this question.
But Jayant, in our practice, what I have seen, though the numbers are not as big as TMH, but steroid is not one of the common thing that these patient takes as a treatment in CS cervix, at least in carcinoma of cervix. In other malignancies or inflammatory or a Hodgkin's kind of thing or a lymphoma, yes, they are quite common. But in a case of cervix or bleeding PV complaints, generally they are not started on steroid even by the GP. Most common thing that they take is basically some or the other hematological supplement. That is one of the common thing that they take. And second is a lot of course of antibiotics, and both of them can change the picture. So steroid is not the fact, but antibiotic and hematological supplements, they are definitely the cause for it.
Even supplemental iron can change these parameters.
Yeah, that's something. The hematological supplements are there. So these are the two things that I have seen patient taking a lot. Yeah, Lavanya, anything you want to add to it?
Yes, sir. In addition, that is the reason we also check the LMR trend during the course of treatment. So I think that will negate it a bit. But then, like you said, sir, we also don't come across patients who have received steroids. We come across patients who receive Tanexa, etc. But not steroids or alternate medicine. They are usually the advanced or recurrent cases where the doctors have given up on patients. That is a common scenario we've come across. And for Chandni's question, this again is a uniform cohort of patients treated with radical CTRT. So neoadjuvant chemotherapy is not a common practice in our hospital. So we will not be really testing that question anytime soon also, I think.
So I think most of the places neoadjuvant is not a very common thing. Very rarely, even in my prior practice also, I come across a neoadjuvant case. I won't say it is uncommon. We see once in a while, but it is not the major bulk of the cases that we see. So still the majority of the cases come to us per primum. Some of the few cases come like triad surgery, but again, this will not change your hematological parameter.
This being 1,000 patients, I think small subgroups will not make such an impact. It's a really big study.
Yeah, it's a really big study, and number of patients, small things is not going to make change.
Yep, I think can we close the session? No, I think on that note we should go ahead and start the next session with the my co-chairperson, Dr. Manish.
Okay.
Shall we ask the organizers now?
Yeah,
hand it over to them.
Organizer take the.
Yeah, take it forward, please. Thank you. Yeah, thank you, everyone. Yeah.
So thank you, Manish sir and Sumit sir for the chairing this session, and also to Chandni ma'am, Lavanya ma'am, and Supriya ma'am for giving your valuable expert comments. And so we come to the end of the gynae session of day 2 of MSA AROI. And now I hand over it to Dr. Anuj for further.
Thank you, Sons. Now we'll have a short virtual tea break from now till about 10:55. And between 10:55 and 11, we'll start with the next session, which is on uro-oncology from 11 to 11:45, followed by hematolymphoid session. And two of the best e-posters which were selected yesterday is being presented as oral today. So one is by Dr. Rupa Balachandran on presentation of Guillain-Barré syndrome as paraneoplastic syndrome in cancer patient, a diagnostic dilemma, and by Dr. Arpit Gite, synchronous occurrence of carcinoma lung and intrahepatic cholangiocarcinoma from Government Cancer Hospital, Aurangabad. So we'll break for tea now and join back at 10:55. Thank you.
Okay.
आवाज नहीं आएगा, ब्रेक ऐसे हो जाएगा।
क्या तुम्हारे क्या टॉकिंग ग्रुप ऑफ आल्सो तो कैसे कनेक्ट हो जाते इसमें से नहीं होता, मेरे को नहीं आता कनेक्ट। यार मेरा है, अभी दे दो मेरे को हेडफोन। यार टॉकिंग ऐसे क्यों लिखा? यार मैं ऑन करूँ क्या मेरा वीडियो?
काम किया उसने यार.
Registrar.
और जो तू मुलानपुर के बारे में सोच रहा है, उसी तरह म्यूट.
Welcome back, everyone. Now we will start with the next session. I invite Dr. Sahil Sood, Senior Resident in our department, for taking the meeting forward. Thank you.
Thank you, Anuj. Good morning, everyone. We shall be starting with the uro-oncology session, which will be chaired by Dr. Bhushan Nimade. He is a consultant radiation oncologist and CEO at Optimus Oncology Private Limited, Nashik, and Dr. Amol Ubale, who is a senior consultant and head of radiation oncology at Sheikh Nandlal Dhoot Hospital, Aurangabad. Sir has a keen interest in precision radiotherapy. Over to you, sir. Thank you.
Hello, am I audible?
Yes, sir.
Yeah. Okay. So thank you, organizers. Coming back to the very interesting topic where there is always a debate about surgery versus radiation in muscle invasive as well as non-muscle invasive bladder cancer. So rather than wasting a time, I would invite the first talk of today's in uro-oncology session, Dr. Prachi Mehta, who will be presenting exploring texture analysis to optimize bladder preservation in muscle invasive bladder cancer. So Prachi, please go ahead.
Good morning, everyone. I'll be speaking today on the role of...
Just go to the next slide. Stop करके वापस करो.
This one.
Now make it full screen.
Good morning, everyone. I'll be speaking today on the role of exploring texture analysis to optimize bladder preservation in muscle invasive bladder cancer. So the treatment options for muscle invasive bladder cancer is either radical cystectomy or bladder preservation. Appropriate selection of patients is necessary for successful bladder preservation. At present, we have the following available criteria, that is clinical, radiological, and pathological. And using these criteria, the current bladder preservation rate is 50%. Hence, newer methods must be developed.
May I request? Sorry, Prachi. Just to may I request everybody to please mute the video so that continue, Prachi. Sorry.
So newer methods must be developed which will correctly identify patients who will benefit on bladder preservation and prevent undue toxicities in the rest. So one of the newer method called texture analysis is ongoing, which is based on quantifying tumor heterogeneity objectively. Texture can be defined as any repeating pattern of local variation in image intensity. Texture analysis provides quantitative measures of extracting features which are not apparent on visual inspection of images and are based on objectively quantifying tumor heterogeneity by analyzing the distribution and relationship of pixel or voxel gray levels in the image. It is based on the central hypothesis that extracted quantitative data reflect mechanisms occurring at genetic and molecular level. The primary objective was to compare texture features between patients with and without recurrence after bladder preservation. The secondary objective were to compare the texture features between normal and bladder cancer, to analyze intra and inter-observer variability, and to compare single and multi-slice analysis of bladder tumor texture features. The eligibility criteria were patients should be more than 18 years of age, having biopsy-proven non-metastatic muscle invasive bladder cancer of urothelial histology, and should have a pre-treatment non-contrast CT scan showing a radiological abnormality of at least 5 millimeter, and should have completed radiotherapy as a part of bladder preservation. Details regarding treatment and outcomes should be known, and follow-up of at least 6 months should be available. So it was a retrospective study carried out from July 2019 to December 2019 in 41 patients. So after the images were acquired in the TextAd contouring software, the region of interest were defined, and later they were passed through an algorithm which removed the unwanted elements like fat, air, calcium, which can hinder texture analysis. Later they were passed through filters which highlighted objects of different size as per the filters used, and later they were depicted in a histogram. So as shown here, the visible tumor was contoured in all the slices for multi-slice analysis. And for single slice analysis, the tumor was contoured in the slice showing the maximal cross-section of the tumor. For normal bladder, the wall opposite the tumor was contoured in 3 consecutive slices. And for inter-observer variability, 3 different observers contoured the bladder tumor independently. And observer 1 contoured the bladder tumor again for inter-observer variability. So after defining the region of interest, they were passed through algorithm and filters. So as here we can see that the size of the objects highlighted will depend on the filter used. So spatial scanning filter 2 will highlight all the objects of 2 millimeters, and so on. As per the different filter used, the object's size highlighted will be different. And later the pixels, the house fill units of the pixels were represented in a histogram from which the first order texture features were obtained. So this step in which first the filters are used and later the histogram is depicted through it is called filtration histogram technique. Coming to results of texture features of recurrence free and recurrence group. So it was seen that the mean of the pixels at both SSF2 and SSF3 were significantly lower than that of the recurrence group at both SSF2 and 3. Using these values, ROC curve was plotted. It was seen that at a mean value of 8.54 at SSF2 and mean level of 14.75 at SSF3, area under curve was 0.714. Sensitivity was 0.8, specificity was 0.4, positive predictive value was 0.66, and negative predictive value was 0.77. Coming to texture features of normal and bladder cancer, so it was seen that almost all of the features were significantly different for normal and bladder cancer. Intra and inter-observer variability was assessed by using intra-class coefficient, and it was seen that both the intra-observer and the inter-observer variability was excellent to good. Coming to multi-slice and single-slice analysis, so as such, there was no difference per se between the two methods of analysis. However, the single-slice analysis could not differentiate any of the texture features which were different for recurrence and control group. So to summarize, the mean of the pixels was found to be significantly lower in the recurrence-free group than the recurrence group at both the filters. At SSF2, the mean standard deviation and MPP of the pixels of normal bladder were significantly higher than that of bladder cancer, whereas at SSF3, entropy and kurtosis were significantly lower for normal bladder than bladder cancer. Overall, there was good to excellent intra and inter-observer variability, and prospective validation is needed to make this conclusion more robust and to recommend these findings in addition to the existing criteria for bladder preservation. The study was unique in that it's the first study evaluating the role of texture analysis in bladder cancer undergoing bladder preservation to predict outcomes of bladder cancer. There was statistically significant difference in the texture features of normal and bladder tumor, which has applications in the field of dose escalation, deciding the need of free TURBT, predicting response to NACT, avoiding biopsy of suspicious lesions on cystoscopic follow-up, etc. There was uniformity in the imaging dataset used in terms of non-contrast imaging and the timing of the imaging, and it used multi-slice analysis. Yeah, thank you.
Okay, I think very good presentation and quite a new and innovative concept. So we would like to call upon next speaker, Dr. Alvina Vedesari. Topic: prospective evaluation of PROMS in bladder cancer, comparing surgery and bladder preservation. So over to you, Dr. Alvina.
Lovely good morning to all of you. This is Dr. Alvina, junior resident at TMH Mumbai. So these are the documents which I will be showing before my presentation. This is a permission letter from University of Michigan Department of Urology for the use of HRQL BCI index HRQL instrument in my study, as well as giving the permission for translation into Hindi and Marathi version. And this trial has been registered under CTRI, Clinical Trial Registry of India, and as on dated 16th August 2019. And this is the Institutional Ethics Committee letter for accepting the study and taking it forward. So bladder cancer is the 10th most cancer in the world, and treatment modalities can range from organ preservation to radical cystectomy approach depending upon the stage of the disease. So there are no prospective randomized trial comparing both of these treatment, but comparative efficacies can only be inferred indirectly. Both these treatments provide the best outcomes in suitably selected patients, but they are associated with unique bag of side effects. Thus, it becomes important to understand its impact on quality of life. The rationality of doing this study was, so the rationality one was the choice of treatment in bladder cancer can potentially influence the quality of life. So it may be decisive that when different treatment modalities and traditional points, that is survival outcomes, are similar, QA consideration should be taken into account. The second rationality was there is no data in the literature comparing QL of the two standard treatment modalities for bladder cancer using a standardized validated set of questionnaire among the Indian population who have a very different socioeconomic milieu as compared to the developed nations. So the primary objective of my study was to understand the impact of both this treatment on different domains of bladder cancer index, and the secondary objective was to compare the URTC QLQ-C30 scores in these patients. So eligibility criteria included patients between 18 to 85 years of age who were able to understand and feel the QL instrument, and who were staged between T1, T4, N0, N1, and who were histopathologically confirmed as squamous or transitional NTMH, and were also treated with standard treatment protocol in TMH. And there was no evidence of disease on routine clinical examination at time of enrollment, and they were at least 6 months after their last active treatment, and they had not received any previous RT to the pelvis and no other history of cancer except incidentally detected CA prostate and cystectomy specimen. So the study methodology consisted of translating the BCI questionnaire in the local language of Hindi and Marathi. So it consisted following algorithm. The English format was translated into first intermediate questionnaire, that is 2 sets of Hindi and 2 sets of Marathi, which was again back translated into English version of again 2 sets. And then it was again translated back into Hindi and Marathi, forming the second intermediate questionnaire. And then this intermediate questionnaire of Hindi and Marathi was used to interview 10 patients as a pilot testing project. And from their opinions and their suggestion, a final questionnaire was devised. So step 2 was after the translation of the BCI to use the BCI as well as EORTC QLQ-C30 in the study for the patients who were post 6 months of the treatment, and then calculation of BCI score as well as EORTC QLQ-C30 score. So I would like to introduce briefly about BCI. BCI is a bladder cancer index. It's a validated and disease-specific, reliable and responsive instrument, and it can be applied across to a range of non-metastatic bladder cancer patients, and as well as in different treatment settings. That is both surgery and bladder preservation approaches. So it is considered as one of the gold standard. It consists of 36 instruments, which are further divided into 3 principal domains of urinary, bowel, and sexual, and further into 6 overall subdomains, that is into function and bother. So showing you an example of BCI consisting of sexual domain, bowel domain, and urinary domain. So it is actually prospective cross-sectional single point study, and we started accruing patients from June 2019. We expect about 150 eligible patients, consecutive eligible patients visiting the OPD, and this study will be continuing till next year, till 31st August 2021. So all the data analysis was done in RedCap software, which is a cloud-based software, and SPSS analysis was done, and mean score across the various domains were compared using independent t-test. So coming to the details of 55 patients which have been accrued till date. So RTM consisted of 26 patients and surgery arm consisted of 29 patients. The median age was 63. However, to note here that median age in RTM was more, that is 67 years compared to surgery arm. The males were more in number, which is the reflection of the epidemiological distribution of bladder cancer. And married and unmarried were equally distributed, about 50% each, and below graduate, above graduate also distributed equally, and comorbidities were also equally distributed, that is without comorbidities and with comorbidities. So T3, T2 stage constitute the major number of patients, and almost 2/3 of the patients have received some form of chemotherapy. So coming to the results of the various domains of the BCI, here we can see that the urinary subdomain function, bladder and bowel function, and bladder sexual function, bladder all had almost equivalent score, but with P significance not with no domain showing P significance less than 0.05. But the important thing to notice here is the sexual bladder subdomain had a greater than 10 point difference, that is 67.77 and 85.78. That is to be taken into consideration. And then coming to the URTC scoring, both the global function and symptom score in both the groups did not show any significant P result. But then on analysis of the sub-item scale, we can see that the role functioning was different in the role function score were different in surgery and RTM, with P value of 0.026. And which was having greater than 10 point difference too. So in the symptom scale sub-item, the pain score also showed significant P value of 0.016, and financial difficulties, though not showing a significant P value of less than 0.05, but having close to it, but greater than 10 point difference. So how is the study different? So it used a validated peer of questionnaire and inclusion of patients treated with modern and advanced approach, and we captured Indian population perspective, and the subdomain of the BCI, that is function and border, have been scored separately, so we can actually differentiate between these two aspects. And we have translated the English version of BCI into Hindi and Marathi, and this translated version can be used in future studies. And this is the study which actually compares head-to-head comparison of QL between radical cystectomy and bladder preservation using radiotherapy, and excluding other bladder preservation approaches like intrarecycle chemotherapy. So other studies, Caffer et al. In 1996 and Mack et al. In 2016, sorry for the mistake, have actually also studied the same, but they were quite different from our study. Caffer et al. Used non-validated ad hoc questionnaire, and follow-up period was about 5 years for both of the studies, and no baseline in follow-up QL was estimated. Caffer included only non-muscle invasive bladder cancer, and Mack included only muscle invasive bladder cancer. Caffer reported better urinary, sexual, and physical psychological score in bladder preservation arm, and Mack reported better general bowel and sexual score in bladder preservation arm, and also better body image. So concluding, so overall QL was good in both the groups. A patient who received bladder preservation approaches using chemo-RT combination had better sexual bother QL scores compared with that who received radical cystectomy with ileal conduit, though not significant, but had a greater than 10 point difference, and lower pain score with a significant P value, and lower financial domain score with greater than 10 point difference. Urinary symptom and bowel symptom score were similar. So considering all this thing, we can think bladder preservation approach is a valid alternative to radical cystectomy. But overall, it is important that patient education and exploration of pros and cons of the various alternative, and promoting active patient participation in the treatment decision is the key to go forward. And capturing all this information information and then discussing it with the patient is of utmost important, as the treatment option may not be the mirror image as that of the treating physician. So I would like to thank everyone for the patient hearing. Thank you.
Hello. Yeah. So coming back to the last topic of this session, in this epidemic era, how the COVID-19 has impacted to us. So may I request Dr. Purnima to talk about COVID-19, a double-edged sword for cancer patient.
Good morning, everyone. I am Dr. Purnima Kale, resident at Department of Radiation Oncology, Mahatma Gandhi Institute of Medical Sciences, Sevagram. The topic of today's discussion is COVID-19, a double-edged sword for cancer patients. The study has been done under the guidance of Dr. Professor Virendra Vyas. This year, 2020, has seen the biggest pandemic spreading across continents, which has crippled many economies, nations, and populations. But this has had a severe impact on cancer patients, as timely treatment is a key management of cancer. But on the other hand, the cancer patients are at high risk of COVID infection due to their compromised immunity and longer duration of treatment. We have tried to analyze the risk of COVID at the cost of delay at a tertiary care center in rural India. Coming to our objectives, our primary objective was to see the patient-related and hospital-related delays in the management of cancer. And the secondary objective was to study the factors affecting these delays in the patient treatment. So we included all the patients who had registered to our OPD from April 2020 to October 2020. Using a patient questionnaire, we collected data regarding the patient's symptoms, their factors relating to the delay of seeking medical care, and recorded both patient and hospital-related delays. The tumor characteristics, number of COVID tests, results of COVID tests were collected from the hospital record. So we'll see the definition of delays that we'll address in the further slides. So the patient-related delay is the time from the onset of symptoms to the first visit to the medical facility. Then in hospital-related delay, we have categorized it into the three categories. First is primary delay. It is the first visit of it is the delay from the first visit of patient to the establishment of diagnosis. The secondary delays from the time of establishment of diagnosis to the time of first initiated definitive treatment. And the tertiary delay was the time from the first initiated definitive treatment to the start of any adjuvant treatment. So we had total 600 patients registered during this COVID pandemic from April to October, out of which 67% of the patients were males and 33% of the patients were females. The mean age of presentation was around 45 years, and we had 20% of the patients in palliative intent and 80% of the patients in radical or curative intent. The site-wise distribution of the patient that we had registered was maximum around 60% of the patient presented with head and neck cancers, followed by 35% of the patient with breast cancer, 10% of the patient with cervix cancer, and almost around 5% of the patient with lymphoma. So this slide depicts the COVID-related delays, the patient-related factor, as well as the hospital-related delay. The y-axis shows the number of days that has been delayed, and x-axis shows the various variables that are available. So in the patient-related delay, we can see that for lymphoma and breast, the delay was quite a lot. It was like around 8 to 9 months. Then followed by cervix, which was around 6 months, followed by head and neck, which was around 2 months. So this is the patient-related delay that we can see in these patients. Coming to the hospital-related delay for head and neck, cervix, and breast, from median primary hospital delay is from the first coming to the medical facility to establishment of diagnosis, which took around 2 months. We have addressed the factors relating to these delays in the further slides, followed by lymphoma, which was around 20 to 25 days. The median secondary hospital-related delay, which is from the establishment of diagnosis to the start of the first definitive treatment, It was around 1.5 months for all of these diseases, and the median tertiary hospital related delays from the definitive treatment to the adjuvant treatment, which was again around 1.5 months in a hospital related delay. So we had interesting COVID-19 statistics in our rural center, where we had 6 out of 600 patients, 593 patients were tested COVID negative. We had only 10 patients testing COVID positive, and we had reported only one COVID-related death. So coming to the factors affecting patient-related delays in this multivariate regression, the factors that affected the patient's delay in seeking the treatment was distance from home. If the patient resided within 50 kilometers of the hospital area, then it was a significant factor that patient could come earlier and seek medical care at the earliest. Then imposed lockdown. Patients from the confinement areas found it very difficult to come to the hospital settings. Then severity of symptom, which was not significant in this patient-related delays. That is, the symptoms were not a significant factor, but availability of personal vehicle was a very significant factor, having a p-value of 0.01, because those who have had the availability of personal vehicle could come to the hospital easily. Education of the patient again was a very significant factor, because straight patients came in early. The primary site, head and neck, breast, cervix, lymphoma, also affected the significance of this variable in the patient-related delays. Now, addressing the hospital-related delays, the availability of doctor was a significant factor, because our hospital caters to COVID as well as non-COVID facilities concurrently. So we also have our COVID postings during the normal OPD thing. So availability of doctor was a significant factor. Then imposed lockdown was not as much significant in a hospital-related delay if taken into account. Then wait for COVID test. At our center, we had to wait for the COVID test result for 24 hours, and hence it was significant for causing the delay in patient treatment at our hospital. Less working hours in the hospital because of the lessened hours of the OPDs also proved to be a significant factor for the delay. Then services available. For a brief period of time, we had only emergency services going on and postponing of the elective surgeries or adjuvant treatment because of the fear and COVID-related emergencies. So primary site, that is head and neck, breast, cervix, and lymphoma, was also found out to be significant in the hospital-related delays. So coming to the conclusion that a large number of cancer patients are subjected to primary patient-related and hospital-related delays due to fear of COVID. Timely active treatment is crucial in cancer patients to achieve optimal control. During this COVID period, a large number of cancer patients have lost their chance of radical cure. Thank you.
Okay, I think all the presentations are finished of this session. So can we move ahead to question and answer?
Please go ahead with the question and answer.
Yeah, so first we'll take questions which are there on Zoom. So I can see first question from Dr. Anil. It's for Dr. Prachi. How have you checked for normal bladder? The bladder wall would be very small in thickness. So Dr. Prachi, can you please answer?
Yes, sir. It was actually difficult to contour the normal bladder wall because it is thin. But using the polygonal tool, I could demarcate it from the other parts and able to contour it.
Prachi, I have one comment or a question basically. Is there any typical CT protocol was followed for texture analysis? That is first question, like slice thickness, EWCW values of CTs. So is there a typical CT protocol followed? Because everything depends on a Hounsfield unit and according to your study basically. The density of the CT will make the difference. And second was, is there any standardized method? Or was there any algorithm or a software which was available to calculate this SSF and whether it is standardized or not? These are two questions.
Yes, sir. So most of the patients CT scan we used were the planning CT scan of 5 millimeter slice thickness. So the images were uniform. And secondly, we used CT solid algorithm for carrying out the texture analysis.
Okay, so 5 mm and not recon to 1 mm or 2 mm. So everything was done on 5 mm.
Yes, sir.
And that gives the better clarity. Like, is that enough to have? Because see, everything depends on your CT quality, which I understand from this type of study. So is 5 mm enough for doing such kind of study, or it should be reconstruction to 1 or 2 mm to get the details?
If I had finer slices, I would be much more easier to delineate both the bladder tumor and the normal wall. But because to maintain a uniformity in the images, we used 5 millimeter images.
And when did this analysis was done? Prior to starting, after starting? Like the time of doing analysis? It is done retrospectively, I know. But at which CT scan you took it for analysis? The before treatment planning CT, or what kind of CT?
Before RTC, before radiotherapy.
So, but you did a non-contrast CT. So you always do non-contrast CT before planning? For bladder?
The images we had were mostly all non-contrast, mostly all
Okay.
the non-contrast images.
Okay. It's quite interesting, basically, to diagnose in such kind of way. So it is good, basically. Or is there any correlation you found out with the cystoscopy with this analysis? Have you done any cystoscopy to verify it?
Yet looked into.
Okay. And it is very interesting study. So that's it from my side.
Okay, so we have one more question from Dr. Girish Bedre, and I suppose it is for Dr. Prachi only. So according to you, what would be the future of AI, that is artificial intelligence in radiology? Would it reduce the role of radiologists? That is the question.
This goes hand in hand. So AI maybe in future to be able to predict a normal bladder area and the cancer area, but at present it has to be confirmed by a radiologist and not just only AI.
So any more questions?
Hi, Bhushan. Can I ask a question?
Yeah, sure, sir.
Hi.
Please go ahead.
So my question is to Purnima. Thanks for putting in efforts in looking at the COVID times. It seems to be a very relatively simple study, but you made some relevant points there. And you found that patients with head and neck, and when you compared head and neck, breast, lymphomas and all, and you found a group of patients who had a long delay. So did you find out why this long delay? It was almost 6 to 7 months in breast and lymphomas.
Yes, sir. Sir, one significant point I want to put forward is breast cancer is the females in our society are given less importance in these rural areas. Therefore, they do not present forward with their complaints in the family settings, and even the other members of the family do not consider the health of the female as a priority. So, and therefore, they seek the medical care very, very, very late as compared to head and neck, which was predominantly male. We had 66% of the patients presenting as males and only 33% of the females in this COVID pandemic. So yeah, the social factor was a very important
So it was more to do with the sex rather than the disease.
So that was the most important thing, yes. And breast cancer also presents with the lump which is insidious and which is not much prominent as the head and neck cancers because it is ulcer growth in the most prominent regions. So yeah, that was also a factor.
So does that also apply to lymphomas also with the same thing? Because I was just thinking, does it have anything to do with the chemotherapy that is given and things like that? See, if you're giving chemo and radiation, there's a likelihood that they will not take it and delay it. The physicians will delay, so that will. On the other hand, if it is just radiation, probably you may end up doing earlier. So that is interesting. I just wanted to ask you that.
Yes, so actually the patient is, yes, sir.
Yeah, can I add? I think it is related to symptomatology also. Basically, see the lymphoma, they have a painless swelling. So it is a primary delay which has happened. If you see the secondary delay and tertiary delay, it is least in lymphoma.
Yes, sir.
They get it treated very fast, diagnosed very fast. But the presentation from the symptoms coming to hospital was very delayed. And probably this is related to symptomatology. They are painless neck swelling, so they are not bothered. And cervix, they have a bleeding. In head neck, they have a pain, probably dysphagia, odynophagia. So I think that is more relevant, I suppose. Because of that only, I think primary delay has happened. And I'm little surprised because lymphoma diagnosis, it takes more time to diagnose. But you diagnose lymphoma very early, you treated lymphoma very early as compared to all other sites.
Yeah.
because we need ISC,
Thank
and there were the ISC was not available. You need to send to Bombay. The sample transport was not available. So I was a little surprised that how come lymphoma got diagnosed very early.
So we have a good pathology department at our hospital. It caters to all the needs very early. So yes.
Okay, so you do immuno ISC also at your side?
Yes, sir. Yes, sir.
Oh,
ISC
so,
is done at our
so
side.
that answer. Oh, anyway, that's.
Can I ask one more small question? Which patients you have analyzed? Means those who came primarily to the hospital before surgery or for the radiation department?
Sir, actually,
breast cancer patient, mostly they are operated at periphery, and after chemotherapy they are referred for radiation, whereas head and neck cancer, mostly they are operated in tertiary care hospital.
Sir, this is a rural care center, a tertiary care hospital. We do not have many hospitals catering to cancer patients in our locality. So maximum of the patients that came to us were naive and fresh, and they were diagnosed at our center. Very few patients were diagnosed at other centers and treated, but I haven't categorized that way because we already had less patients enrolling to us during this COVID pandemic. But yes, sir, mostly they were the fresh patients, and some were treated outside and came for radiation or chemotherapy.
Can I ask a question?
Sure.
Amul?
Yes. Yeah, please go ahead.
Yeah, so Purnima, very nice work and nice presentation. So do you have a timeline of patients who were presenting in non-COVID time, either like before the lockdown or probably now, which is near normal, not exactly normal, but still near normal? To compare, like actually did COVID affect, or this is the normal trend of our patients to hang on with the symptoms and disease? And because hospital facilities were much more less crowded, they would have worked quicker right now that time than now. So I don't know which side has worked slow and which side has worked faster today. You know what I mean?
Yes, sir. I want to put forward one point that during this COVID pandemic, in the, almost around 6 months, we had only 600 registrations, whereas in the non-COVID era, we have almost 200 registrations per month. So that is a significant enough factor to know that there were very few patients coming to the hospital facility, and even the hospital-related delays were significant during this time. So
yeah. So I think it's better that if you continue this study and get a trend of non-COVID time also, to understand whether the patient delay is still similar, but the hospital delays increase as our the COVID era is getting over and we are getting into a non-COVID times. And then it will really give a better overall holistic picture of things that are on the ground.
Sure, sir. Sir, I'm looking forward for it. Yes, sir.
Yeah, that would be a very good idea.
Nice work.
Thank you so much.
So we have one more question for Dr.
Anil, I had
Purnima.
two more questions for Alvina and if you permit.
Okay.
Alvina,
okay. Please go ahead. Please.
Yeah.
Good morning,
so Alvina, hi. How are you? Nice presentation.
Thank you, sir.
And great work, because it's a long things that you have done, huh? Translated and did everything. So now you have 55 patients that you have analyzed, right? So suppose your number will go to 200. What is your final number for the study?
So we are expecting about 150 patients in total.
150. So 3 times the sample size that you will have. So which other domains that you would like, right now you showed sexual and some functional things were better in radiotherapy as compared to surgery, and other are similar, right? So which other factors do you think they will become significant just with the increase in the sample size to 150 if the trend remains same?
Yes,
if the trend is similar.
So I think the financial.
If you looked at your data, that's how you can.
Yes, the financial domain.
Okay.
And also the social functioning of the social domain, social subdomain will actually show significance in future, sir.
And why do you say so?
So actually, the trends are close to it, and I expected. I also interview the patients. So taking all this perspective, I think these two domains are going to perform better in future, sir.
Hello, good. All the best. Let us know the final results with that.
Thank you, sir.
Okay. So Prachi, yeah, thank you. Is Prachi there?
Yes, sir.
Yeah, hi Prachi.
Hello, sir. Good morning.
So nice work. I think all the scans that you used were CT simulation scans, planes. That's why they were all plain CTs, right? That's what somebody was asking before. Bhushan was asking, right? So the main thing that I wanted to ask you were, did you differentiate the patients who recurred in the original tumor bed and those who recurred in the remaining normal bed? You know what I mean to say?
Yes, sir. So not.
Suppose you had 10 recurrences.
Yes, sir. I have not.
So 5 were in the. Why I'm asking you this question, because you're predicting on the baseline radiology to have a tumor later on, right?
Yes, sir.
Right. So if a kind of a tumor bed which is predicting for a recurrence in the same site, and a kind of a normal bladder wall which is predicting for another recurrence.
Okay.
Can we do that in your analysis in future, or look into it?
Yes, sir. We can.
Have you understood what I'm asking you?
Yes, sir.
So if you have 10 recurrences, I suppose 7 will be in the tumor bed and 3 will be in the normal bladder at that times of the simulation scan, right?
Yes, sir.
So which are those 3 normal looking bladder versus 200 which got the recurrence there, versus 90 patients who in the original tumor bed did not have a recurrence but 7 had?
Yes,
Is
I'm
that,
not. Yeah, we can do
does
that.
that make some sense?
Yes, sir. We can do it because all
Yeah.
the high risk features like presence of CIS, multifocality will lead to that thing. But I've not looked into specifically into the site of recurrence in my study.
Yeah, so it could give a good dimension, I suppose.
Yes, sir.
Sure. Good.
Thank you, sir.
I think any more. I don't see any questions in the chat box now.
So there's another
There are
question.
questions there on YouTube. Dr. Anil,
YouTube.
Anybody following YouTube? I'm not
No,
logged in.
YouTube I'm not following, so I don't know. Basically.
There's a question by Dr. Anil Tibdewal for Dr. Purnima. Did you see
One question.
Did you see any difference in patient characteristics over pandemic time, like more locally advanced than early?
Sure, sir. Because initially it was easier to communicate, and transportation was easier, so the rural patients could afford and come to the facilities quite often, and they were diagnosed in relatively earlier stages. Whereas when we have delay of like 6 to 8 months, so yeah, patient presented with the locally advanced stages.
I think we can wrap up this session now. Is that okay, Amol?
Yeah,
Rahul, is that okay?
Comment from Dr. Rahul? Yeah. Because Dr.
No, I
Gopal
think
is
it was
not
an
there,
excellent
so
session and nice discussion. Very good. I think we can go.
Yeah. Over to your organizers.
Thank you. We end this session of urology with an interesting talk. We thank our chairpersons, our expert speakers, and our participants for the session. We now start with the final session for the day, that is Hodgkin's lymphoma and best poster session. This shall be chaired by Dr. Pramod TK. Sir is a Director and Chief Operating Officer at Optimus Oncology, Latur. He has a keen interest in treating head, neck, gynae, and brain tumors. And a second chairperson would be Dr. Nehal Khanna. Madam is a professor at TMH Mumbai in the Department of Radiation Oncology, and she specializes in treating pediatric and hematolymphoid malignancies. Over to you, sir and madam. Dr. Pramod, you'll have, can you please unmute yourself?
Thank you, organizers, for arranging such a wonderful virtual conference. So in this session, our first speaker will be Prarabdh Singh. He is a junior resident 3, and he will be presenting his audit on role of radiotherapy in extranodal natural killer T cell lymphoma. So, Dr. Prarabdh Singh.
Back in 1890, this tumor was also known as lethal midline granuloma or gangriosa rhinitis progressiva. Today, good morning all of you. I'm going to talk about a topic, NK T cell lymphoma, that outworks distinct entity in WHO classification. I'm going to talk about the role of radiotherapy in NK T cell lymphoma as an audit. Starting with the background, NK T cell lymphoma are EBV-related non-Hodgkin's lymphoma with rare incidence. They are divided into nasal, non-nasal, and disseminated subtype. Nasal lymphoma involves nose, nasopharynx, and upper respiratory tract. Non-nasal lymphoma involves skin, GIT, test, and other sites. This is the causative factor for the lymphomas. Basically, they are three cause known factors of EBV virus, genetic predisposition, and use of insecticide and pesticide, well-known cause of the lymphoma. Moving to the management part, for the initial stages of 1 and 2, the treatment remains chemoradiotherapy, while in the advanced stages, the treatment is confined to the chemotherapy only. We have the various literature reviews from the Korean, Japanese data regarding the role of and impact of the radiotherapy in outcomes of the NK cell lymphoma. For example, Kim et al., Ribog et al., and Cheng et al. And why do we need a study? So, there's a paucity of the robust literature available on the outcomes of the NK cell lymphoma in the patient treated with the radiotherapy. We have less number of patients in most of the studies because of heterogeneous treatment regimens used. We have lack of outcome data specifically in the Indian setting. So objectives of my study, the primary were to assess the local region control rate. The secondary was to estimate the oral survival, to assess the disease-free survival, and to evaluate the toxicities. This study was retrospective, observational, single-arm study. The eligibility criteria include all the patients with the histopathologically proven NK cell lymphoma who had been treated with the radiotherapy in TMH ACTREG from 2000 to 2020. We have taken the age limit of more than 18 years and all the patients who have been received treatment in the TMH, ACTREG or outside. We have excluded the patient whose details of ABRT was not available with us. We have analyzed overall survival and disease-free survival using Kaplan-Meier method, and the statistical significance of various variables was calculated using the log rank test. All the analysis was done using the SPSS version as cut of 30th June 2020 for time to event outcomes. So yes, we got interesting results. Total number of patients accrued is 52 patients, in which 48 were curative and 4 were palliative intent. Median follow-up was 53.1 months, ranging from 12 months to the minimum to 130 months maximum. Median age was 42 years. Male to female ratio was 36 to 16. Most of the patients were diagnosed in the early stages, and out of which 27.5% was EBV positive. The treatment modality used was RT alone in 2% of the patient, RT followed by chemotherapy in 8%, and the maximum had chemotherapy followed by radiotherapy, that was 88%. The median RT dose was 50.4 gray in 28 fractions, ranging from 12 gray to the minimum and 54 gray to the maximum. So this is a bar graph denoting the complete response, partial response, and progressive disease in terms of the response to the radiotherapy. We can see maximum patient achieves complete response. Likewise, moving to the toxicity part, we have documented 3 main toxicities: skin, mucositis, and dysphagia. Interestingly, we haven't seen any grade 3 and grade 4 toxicity. Maximum patient with skin was a grade 1 toxicity. And so, moving to survival outcomes, we have Kaplan-Meier curves of the overall survival, disease-free survival, and local regional control. The result was that the total 5-year overall survival was 44%, the disease-free survival was 42%, and local regional control was 77%. On further analysis, we found that number of sites involved has specific impact on overall survival and disease survival with p-value of 0.0087 in disease-free survival, and in terms of survival, it was 0.006. Interestingly, we also find that post-response of radiotherapy, the patient who achieved complete response has impact on DFS and the local region control with significant value of 0.001. So, we have came to the conclusion that radiotherapy plays a pivotal role in treatment of NK cell lymphoma. This figure denotes initially the patient had a very gross disease, and when the patient was treated with the radiotherapy of 50 gray, the tumor disappeared. So I'd like to conclude my topic. Thank you so much.
Thank you, Prarabh. It was nice presentation. I would invite our expert on this topic, Dr. Deepak Dangwal, and also Dr. Laskar to have expert comment on the presentation.
Hello? Audible? Hello?
Yes, sir, you are. Yes, Deepak, you are. Go ahead.
Yes. So, Prabhat, it was a very nice presentation on a relatively very rare topic. Actually, frankly speaking, I have seen only 2 cases in my private practice as of now, and both were like nasal types, fortunately. So, I have 2 questions. Like in your entire presentation, your group, none of the patients received concurrent chemo radiation because it is one of the standard treatment unfit patients. Like.
So, can you repeat, sir?
None of your patients received concurrent chemo, no, with radiation?
Yes, sir.
So why was that?
Apparently, maximum patient received the sequential chemotherapy followed by the radiotherapy. Only one patient had because of some hematological parameters are not fine, so he received along with the concurrent with RT.
So what was the reason for not giving concurrent chemo? Was it the patient general status or hospital policy or DMG?
So we have less dose of chemo. Because the patient has some altered GFR profile, so we just gave along with the chemo.
And I think most of your patients have received chemo upfront, then RT.
Yes, so that's maximum patient on a sequential course, chemo followed by RT. Only one patient.
Yeah, because there was a recent meta-analysis which has clearly shown that upfront RT gives a survival benefit. So, can you explain this? Did you get my question?
Sorry, second question.
So NKT cell being a very radiosensitive histology, and there is a recent meta-analysis and also a lot of studies which have shown that upfront RT gives a survival benefit. It is better than giving RT later.
So various data we have that RT doses, for example, in our institute, if the dose is escalated 60, it has better outcome. So, likewise, we have a better outcome with the RT alone.
No, you're not getting my question. I'm asking
So
upfront RT versus sequential RT. Yeah, maybe sir can tell.
Prarabh, the question, I can answer, but it is he should be answering. No. So Prarabh, the question that Dr. Deepak is asking is, there is more and more evidence coming which says that probably you should give radiation first and follow it up with chemo, or you can also do a combination of concurrent chemo and radiation. So Dr. Deepak's question is, why in your series of patients, you are only showing majority of patients receiving chemo first, followed by radiation? Is it because of an institutional policy, or is it because some specific reason that you're giving chemo first and followed by RT?
So institutional policies remain the sequential chemoradiotherapy only because of the institutional policy only, TMH.
So yes, Deepak, the question and the answer is actually that. So it's more of institutional policy that we are doing chemotherapy first, followed by
because radiation. As you said, most of the data is now showing RT is like beneficial when given upfront.
Yes.
Yes.
So yeah, so the evidence that is coming more from the Japanese and the Koreans is that if you give radiation first and then back it up with chemotherapy, the outcomes are better. And that is the meta-analysis that you were talking about.
Yeah,
so
and also ESCO suggests that if it belongs to the low risk as per the pink prognostic criteria, in low risk you can essentially start with RT first. Maybe an intermediate risk because chances of distant bets are high. You can give chemo first and then maybe go for RT. So it is very important. I think you missed that pink prognostic criteria.
Yeah. So Prarabh, do you want to tell what is the criteria, the prognostic criteria that Dr. Deepak is talking about?
So we have various criteria, for example, International Prognostic Index. What are the pink criteria, sir? One is pink E criteria. That includes all the hematological parameters, that includes LDH level, age criteria, which has to be incorporated for the this treatment outcome. So we have included even the EBV titers along with the other parameters to quantify for the outcomes. So basically we include age, sex, and the LDH level and response to therapy as the outcomes criteria.
Is
you
that
tell me the pink
criteria? Correct.
The pink criteria is basically, age more than 60, stage 3 or 4 disease, non-nasal histology, and distant nodal metastasis. So low risk basically means no factors. In low risk, because the chances of distant mets are low, you can primarily start with RT upfront and then maybe go for a sequential chemo. Or you can go for, if patient is fit, you can give for concurrent chemo radiation followed by adjuvant chemo. If intermediate risk, because chances of distant mets are high, it is better to go with SMILE chemotherapy followed by RT. And non-nasal are basically treated as high risk, so there is no role of RTS. So only in consolidation you may consider RT. Sir, please correct me if I'm wrong.
You're perfectly correct, Deepak. You are an expert. So Nehal, would you want to add something to? Then I will tell something else later on, why at all discuss this very rare kind of a thing with so little numbers that we have. why at all discuss and waste Anil's time in the thing in the seminar and thing. So that is the important thing that comes up. So maybe after Nehal has made her comments, and I would like to say something about why this study at all.
Can the organizers unmute Nehal? Can
Nehal, you need to
No, 1 minute. Organizers, can you unmute Nehal?
So actually, I would request Dr. Laskar, Dr. Deepak and Nehal to be with us. I think we will collect all the questions. We will go ahead with the posters and then again come back to questions.
Sounds good. Sounds good.
Yeah, so in the poster series, 5 posters were presented, of which 2 are selected. And the first poster is by Dr. Rupa Balchandran. She is JR3 at Government Cancer Hospital, Aurangabad. And she will be presenting her poster as presentation of GB syndrome as paraneoplastic syndrome in cancer patient, a diagnostic dilemma. So over to Dr. Rupa Balchandran.
Dr. Rupa, can you please share your screen? Dr. Rupa, your screen slide is visible. Can you please start?
Yeah. Good morning, all. Can I start?
Full screen, please.
Full screen.
Yes, you are visible.
Yeah. Good morning, all. My topic of paper presentation is presentation of Guillain-Barré syndrome as paraneoplastic syndrome in cancer patients, a diagnostic dilemma. I've done this poster under the guidance of Dr. Mahesh Ravadkar, Associate Professor, and Dr. B.K. Shevalkar, Professor and HOD of Department of Radiotherapy, Government Cancer Hospital, Aurangabad. Paraneoplastic syndrome is a term used to refer to the disorders that accompany benign or malignant tumors, but are not directly related to mass effects or invasion. These neuropathies are often masked by concurrent neurotoxicity from chemotherapy and other cancer therapies. Here we are reporting a case of 40-year-old female who was diagnosed as Guillain-Barré syndrome in a known case of triple-negative breast cancer who was on second-line chemotherapy. She was not hypertensive. She completed 3 cycles of chemotherapy using epirubicin, cyclophosphamide, 5-fluorouracil, followed by 4 cycles of paclitaxel and carboplatin, and adjuvant external beam radiation to left chest wall and supraclavicular fossa as adjuvant to left modified radical mastectomy. After adjuvant treatment, she was on regular follow-up on OPD basis. Then after 7 months, she presented with left axillary infraclavicular intramembrane intrathoracic lymphadenopathy, which was confirmed clinically and using CT thorax. We started her on second-line chemotherapy using single-agent nanosomal docetaxel lipid suspension. Then patient presented with gait disturbances 2 weeks after a 3rd cycle of this chemotherapy. The clinical presentation was, she presented with symptoms like headache, vomiting, both lower limb weakness and slurred speech. And signs, they were left eye enophthalmostosis, deviation of tongue to right side, and bilateral lower limb proximal muscle weakness to a power of grade 2. Her investigations were done, CBC, LFT, KFT, electrolytes, serum protein, vitamin B12, creatine phosphokinase, ADA were range. CT abdomen and pelvis 2D echo was normal. CT chest revealed significant reduction in size of the chest wall lesion, suggesting good response to the chemotherapy. So we suspected brain mets and started her on steroids and mannitol. But MRI brain with spine was normal. However, patient's neurological symptoms clinically suggestive of intracranial spread, but MRI being normal with no targeted lesion, which led to diagnostic dilemma. So neurofusion opinion was taken. Nerve conduction velocity suggestive of axonal demyelinating sensory motor neuropathy. And so as per neurofusion, it was a case of polyneuritis cranialis with polyneuropathy. We suspected as nanosomal docetaxel-induced neurotoxicity, which was uncommon. But IV immunoglobulin, vitamin B3, B12, and other supportive treatment was started. This shows a nerve conduction study done. Patient but developed vomiting, headache, fever. CSF cytology showed suspicious malignant cells. So with suspicion of leptomeningeal involvement, we started her on empirical intrathecal methotrexate, hydrocortisone, and cytarabine single dose. So while giving intrathecal methotrexate, a second CSF cytology sample was taken, which showed negative for malignant cells, 1 to 2 pus cells, and raised serum protein, CSF protein. So a neurologist's second opinion was taken, and to our surprise, it was diagnosed as paraneoplastic neuropathy, acute inflammatory demyelinating polyneuropathy or Guillain-Barré syndrome, and restarted on immunoglobulin. But patient developed respiratory muscle paralysis, went into respiratory failure, multi-organ dysfunction, and expired in ICU course. So discussion. Guillain-Barré syndrome is an autoimmune disorder that is thought to be a post-infectious polyneuropathy involving mainly motor but also sensory and sometimes autonomic nerves. The relevant points suggesting Guillain-Barré syndrome were signs of demyelination on nerve conduction study, elevated CSF protein levels with normal cell counts. So in our case, the GBS syndrome was idiopathic in onset and not related to nanosomal docetaxel-based chemotherapy. So to conclude, paraneoplastic GBS is a very rare but life-threatening disease. GBS in cancer patients should be differentiated from chemotherapy-induced toxicity and neuropathy, particularly as we have effective treatment which is available for GBS like paraneoplastic syndrome. Thank you all.
Thank you, Rupa. Nice presentation and very confusing and enlightening case. May I call upon our second speaker to present his poster, Dr. Arpit Gite, JR3 in Government Cancer Hospital, Aurangabad. He will be presenting synchronous occurrence of CA lung and intrahepatic cholangiocarcinoma.
Good morning, everyone. My slide is visible?
Yes, it is.
Good morning, everyone. I am Dr. Arpit Gite, Junior Resident 3, MD Radiation Oncology. I am presenting a rare case of synchronous occurrence of carcinoma lung and intrahepatic cholangiocarcinoma under the guidance of Dr. B.K. Shavakar, Professor and HOD, Department of Radiation Oncology, GMC Aurangabad. So, a 14-year-old male presented to our OPD with chief complaints of abdominal pain, right hypochondriac region, vomiting and breathlessness since 1 month. And he had a history of 25 years of cigarette smoking. He denied any alcohol use, any occupational exposure, allergies. He came with HRCT thorax with a suggestive of 3.7 centimeter ill-defined soft tissue density mass region in right hilum in anterior segment of right middle lobe, causing invasion of mediastinum with multiple lung nodules with nodular septal thickening in right middle lobe, suggests possibility of metastatic lesion with lymphangitis carcinomatosis, mediastinal lymphadenopathy present in paratracheal area of size 3.2 centimeter. He came also with a report of CCT abdominis, which was suggestive of the multiple small hypotenuse lesion in both lobe of liver of approximate size 5 centimeter, few showing remenacement. There was no evidence of intrahepatic biliary radical dilation, portal vein was normal. Gallbladder is also partially distended, wall shows pseudo thickening, no evidence of radiopaque calculi or any intraluminal mass. So we have taken biopsy from liver mass, which was suggestive of poorly differentiated carcinoma, of which we did ISC. On ISC, the markers were positive for CA19.9, CK7, and CA19 weakly positive, and negative for CK20, synaptophysin, HEPAR1, CA, TTF1, CD56, and CDX2, which was suggestive of intrahepatic cholangiocarcinoma. Then we ordered a whole body PET scan, which was suggestive of FDG with heterogeneous enhancing ill-defined soft tissue mass region of size 43 by 38 mm, involving right parietal region extended to anterior segment of right middle lobe, with mediastinal lymphadenopathy, with permanent mets in the same lobe, and with FDG with multiple varying size peripheral enhancing lesion with both lobe of liver suggestive of liver mets of size 51 by 48 mm, with abdominal lymphadenopathy. You can see here, the mass is here in the right middle lobe, which was primary with speculated margin regional lymphadenopathy mediastinal, and both lobe of liver shows metastatic liver disease. So we have done tumor markers also. Serum CA19.9 marked raised, it's about 33,499, C was 4.39. So in view of already metastatic disease with ISC confirmation, we plan for gemcitabine plus cisplatin based chemotherapy 3 weekly, as it will be effective for both type of cancer. CT guided biopsy and bronchoscopy guided lung biopsy of that primary lung lesion was not possible due to iatrogenic pneumothorax and inaccessibility of bronchial lesion respectively. Hence, we could do only bronchial brushing cytology, which was positive for malignancy. So he has taken 3 cycles of gemcitabine cisplatin chemotherapy, and he just completed now. And he came with a post 3 cycle CCT chest, abdomen, pelvis. Post 3 cycle CCT chest, abdomen, pelvis suggestive of ill-defined heterogeneous in soft tissue density nodule with spiculated margin in right middle lobe, approximately size 7 by 8 by 7 mm. Previous it was 5 centimeter around, with few sub-centimeter mediastinal lymph node, largest by 9 by 5 mm. Previous it was 3 centimeter on PET CT, showing significant reduction in size, suggestive of more than partial response. And ill-defined heterogeneous lesion noted in both lobe of liver of around 8 by 8.8, suggestive of neoplastic etiology with multiple hypotenuse hypoenesic lesion in both lobe of liver, suggestive of liver mets. This is the pre-chemo scan. We can see PET CT, and this is the post-chemo scan. There was significant reduction in the lung size lesion, and liver lesion were stable. So we also did serum CA 19.9 post 3 cycle, which is now 13,897. Previous it was 33,499. So post 3 cycle chemo, there is a radiological response for carcinoma lung and serological response for intrahepatic cholangiocarcinoma. Also, there is 60 to 70% subjective response, significant delay of symptoms such as breathlessness, weight gain of about 5 kg. Hence, we plan to continue for 3 more cycles of chemo. In conclusion, this is a rare case of synchronous carcinoma lung with intrahepatic cholangiocarcinoma. For the treatment point of view, accurate diagnosis of this rare presentation necessary, which depends on morphological characteristics and immunohistochemical staining. Thank you.
Thank you, Dr. Arpit. Now we can move to questions. So before questions, I would request Dr. Laskar to tell about why the study was done, the role of radiotherapy in NK T cell lymphoma.
Dr.
So
Arpit,
maybe
can you please, sorry sir, Dr. Arpit, can you please end your slide share?
Nehal has to make some points, and then Nehal,
Yes, sir.
tell us something about why.
I'm still mute.
So that was Pramod who actually kept you
We
muted.
can hear you. We can hear you, Nehal.
I still see that. Okay. Oh, my fault. So I would like to say that all 3 presentations were very good. I would like to congratulate Dr. Rupa and Dr. Arpit for picking up this kind of a rare presentation so that they could optimize that treatment accordingly, especially in the case of GBS where a very effective treatment is available. It's a life-threatening event, but very effective treatment is available if you can initiate the treatment fast. Regarding Prarabdh, it was a very good presentation, but I would like to acknowledge Dr. Deepak's comment also. I agree with the recent meta-analysis that says that probably giving upfront radiotherapy is adds on to improving the outcomes. But till this meta-analysis, we were really unsure, and I don't know how much we can extrapolate the results of this meta-analysis onto our population also. If you look at Prarabdh's data, it's only 50% of the patients who have presented with early stage disease. And even in early stage, at times you have a large volume local disease. In those patients, you would like to offer chemotherapy first. I agree it's to an extent an institutional policy also, but you would want some shrinkage of the tumor so that radiotherapy also becomes tolerable. The outcome, irrespective of the treatment approach, remains a little suboptimal as compared to other lymphomas.
I saw Jayant somewhere. So Nehal, you're very right. So maybe we can get some comments from Jayant. Jayant, I saw you. There you are. You're hiding underneath that euphony.
Okay, excellent presentation, Prarabdh.
As far as NKT cell lymphomas are concerned, Deepak, you rightly said that there is this meta-analysis which says that upfront RT is better in terms of progression-free survival and overall survival for early stage NKT cell lymphoma. But one must understand that this particular meta-analysis was done using retrospective studies. Of course, you cannot do prospective randomized studies in NKT cells. And then they did not use the chemotherapy regimen which we now use, that is the SMILE regimen. They were all using CHOP or GLOX based regimens earlier, or LVP regimens. Now we have this SMILE regimen, which is considered to be a more potent regimen for that of NKT cell lymphomas. And that's the very reason why we are using this particular SMILE regimen. We cannot use concurrent RT along with the SMILE regimen because of the reason that we can have lots and lots of toxicities, especially mucositis. So that's the reason, as an institutional policy, we are using SMILE at first as an induction chemotherapy, followed by that of radiation treatment. That's one of the reasons. This is an institutional policy. The second reason, in our patients, usually very rarely will get a stage 1E tumor. Usually we'll get a stage 2E tumor as far as early stage NKT cells are concerned, where it will be involving the maxillary sinus or maybe going into that of the nasopharynx. So in such a situation, the volumes will be quite big. And when the volumes are quite big, then you cannot use the concurrent chemotherapy along with that of radiation treatment. And the third reason is, I'm just forgetting, I was trying to recollect the third reason why we are not doing this. I don't remember now. These are the two reasons actually which came into my mind. So we have now
because
changed
we don't
from,
get radiation dates, probably. Is that the
maybe
one?
It's not that this thing. I mean, as Girish has said, the waiting list is not that much as of now. The third reason is that we are giving higher doses of radiation in NKT cell lymphomas. We are not, unlike that of the B cell lymphomas, where we give between 36 to 45 gray, which is enough. NKT cell lymphomas, like T cell lymphomas, are more radio resistant, and we are giving more radiation doses. The more the radiation doses, the more the toxicity when you're giving it along with that of concurrent chemotherapy. So all these three reasons are coming to my mind as of now that we are doing. That's the reason why we are not doing concurrent chemoradiotherapy, but giving induction chemotherapy first, reducing the volume of the disease, and then giving small volume RT using IMRT technique.
Sir, any experience about less toxic regimen concurrent like cisplatin followed by VADL?
So there is one Korean study. It was a phase 2 prospective study of concurrent cisplatin along with that of radiation treatment, followed by chemotherapy as an adjuvant, further adjuvant chemotherapy. So this particular Korean study showed improved outcomes along with that of cisplatin, but you have to understand that the mucositis, when you're giving cisplatin along with that of radiation treatment in NKT cell lymphomas, was in the tune of more than 40%. That is the very reason that's the very reason why many of the institutes don't give concurrent chemoradiation.
So how much dose do you think should be optimal? Means 50 gray or 60 gray?
Okay. So, sir, do you want to answer this question?
No, go ahead. I'll collect all the answers and I'll say that I said.
Okay, you'll give the final answer then. All right. So it's a very good question. And this question is actually pertaining to all the junior residents who should know that NKT cell lymphomas are more radio resistant. So when you're giving as a RT alone, standalone treatment, you should go up to doses of 254 to 55.8 gray, as I had already mentioned before, because NKT cell lymphomas, like any T cell lymphomas, are more radio resistant vis-a-vis as compared to that of the B cell lymphomas, which are more radio sensitive. However, when you are using induction chemotherapy or when you are using concurrent chemotherapy along with that of radiation, you can reduce the doses to around 50 gray, but not less than that. Anything less than 45 gray is detrimental in NKT cell lymphomas. Better than that of 45 gray is always better, with better outcomes in NKT cell lymphomas.
So perfect. Actually, so Pramod, I don't have to answer anything more. Just one point. We talked about dose. We talked about sequencing. The only thing we didn't talk about is the volume. If you treat NKT cell lymphomas, do you just treat the involved paranasal sinus, or do we include all the paranasal sinuses in this? So that was one thing. So I will ask Prarabh to answer that question. If he doesn't, then I will answer the question. So Prarabh, do we need to treat only the involved paranasal sinus, or do we need to treat a wider volume, and do we have evidence towards that?
So
And another question, if I can ask Prarabh at the same time, I want Prarabh to answer this. What would be your DDs when these patients present to you? Because you talked about them as being fatal midline granulomas. So what would be your DD if a patient presented to you?
Now, one of the main DD will be Wagner's granulomatosis, ma'am. Which could be diagnosed with exclusion. Along with that, ma'am, does really seen the population like rhinosporidiosis, one of the common infection. There could be also
and the third one? You've heard about midline nut tumors?
Ma'am, it could be ma'am, sorry, ma'am.
Nut tumors? Have you heard about them?
That also, yeah, ma'am.
Please go ahead.
So should I say so?
Volumes.
Yeah, of course.
Yes. So as per the latest ILROC guidelines, we have just contouring the nasal and the Valdes ring. In the nasal, if it's unilateral, confined to the anterior middle third of the nasal cavity, we have to include the maxillary, whole of the maxillary sinus. But if the tumor is confined to the bilateral nasal cavity, we have to include the whole of the nasal cavity along with the hard palate and the ethmoidal sinus too. While said that nodes has not, the evidences have shown that irradiated node is not beneficial as such. While in the case of Valdes ring lymphoma, we have contoured the whole of the Valdes ring along with the surrounding structures. So basically, we have to see how much area has been occupied by the lymphoma. As per that, we have to contour the specific areas. So if the disease is bilateral, we'll contour the cavity and the hard palate too.
So that's that last one point I wanted to bring up. And I will link it up to why our study is important. So the last point they said, and the people who have been working with me would realize that we completely don't do that. We just treat the volume that is involved and the lymph nodes that were involved, we treat that. If the PNS is involved, if you've been working in my unit, we do not treat the maxilla, we do not treat the nasopharynx. So that is why Prarabh study is important, to look at your results. Did you have inferior outcomes? And we have a median follow-up of 50 point some months, and we have early stage disease in almost 50% of patients. And our local control was 76%, which is exactly the same like what you see in the Japanese and the Korean studies. So probably what they are saying that if you have just the PNS involved, if you have the PNS involved, you need to treat the maxilla and this and that. Probably that is not required, and that is what we are seeing. And that, very importantly, Jayant pointed out a very important factor. All these Japanese and Korean studies, they have not used SMILE chemotherapy. They have used a less aggressive chemotherapy. So we are using SMILE chemotherapy. We have been using radiation and as an adjuvant. So probably, like Nehal also pointed out, just because you are treating early stage disease doesn't mean that they are not bulky. So if you have early stage disease, if you are probably giving SMILE or aggressive chemotherapy, then possibly reducing the volumes of your radiation may not be detrimental. That is one message that is coming out from Prarabh's thesis. And this is good data of 50 some patients treated over a period of 10 years. I was looking at whether this data is very suboptimal and small in numbers. If you look at the SEER data for I think 10, 12 years, they have from all over the US, they have about 500 or 600 patients. So this is not small from a single institution. And even if you look at the published series from the Eastern Asian countries, the highest number is I think 65. So this is relatively good. We have some new information coming from this study. So this is not as simple study as it looks like. So if we look in depth, this is one of the studies that we did similar to what Deepak's thesis was. It looked like a simple study, but it defined that you can actually reduce the doses of radiation in early stage unfavorable Hodgkin lymphomas. So it's similar like that. So there is a contribution to literature from Prarabh's thesis. That is, I think, what is important. Rest of the things we have all discussed, how it should be treated, how the natural history is different, how the chemo is different. We don't treat with CHOP chemotherapy, how aggressive chemotherapy should be used, and the other concept, unlike conventional non-Hodgkin's lymphomas, we probably need to use RT earlier than. So I think Anil is looking into the screen that sends a signal. So we will probably hand it over to Nehal back and Deepak, I think, and Pramod probably, and then we can go back. I'll keep quiet now. So thanks. I think I enjoyed. Maybe we can have more such sessions in the future. So thank you very much, Anil. Congratulations to you. You did a great job, and I'm enjoying from Guwahati.
Thank you, sir.
Thank you, sir.
And good to have all my students on board, actually. And the real and the true ones, and the not very real ones. Deepak, where is
Thank you,
Prakash? Thanks a lot, Prakash.
Prakash is enjoying Sula in Nasik.
So there are a few questions in the chat box. Question by Dr. Jayant. Were all patients treated with IMRT?
Not definitely, sir. Not all patients treated by IMRT. Some are with 3D CRT also, and some are definitely with IMRT. So we'll see equal portion of both 3D CRT and IMRTs in treatment.
But the interesting thing was that we didn't see toxicities. You said that the toxicities were not grade 3. And that may be because, most of the toxicities that you see is mucositis. And here we were talking about the PNS. Yes, and obviously we used 3D conformal. So that's why we didn't. Nehal?
Yes, sir. There's a Chinese study of 1,600 patients which says that IMRT shows improved outcomes. So,
and that is because they contoured better?
I don't know. This is what they say. Maybe better conformality because we know it's a paranasal area. Homogeneous dose distribution with 3D CRT may be difficult in some cases. So IMRT would have led to a more conformal dose distribution and homogeneous dose distribution.
Yes, ma'am. There was a study by Tomita et al. Also. The pilot study with the 3D CRT and IMRT. He took around 16 patients.
महीने में 2-3 बार इनकी कैटरिंग में कुछ बच जाता था तो हमको देती थी वीक में 1-2 बार तो मिल ही जाता था हमको
राइट टाइम टू टॉक अबाउट केटरिंग
तो मैसेज था हमारा
वाला था उन शादी का केटरिंग का उनका था या फिर कोई फंक्शन का मैडम thank God he's not talking about Zomato.
Arab, can I ask you a question?
Yes, sir.
How would your volume change after when you use chemo up front and then RT? How would your volume?
So what, sir? Sir, audible.
Means, will you take pre-chemo volume or post-chemo volume?
Sir, we'll include a pre-chemo volume, sir.
If you are using pre-chemo volumes, then how is it benefiting you in terms of reducing the volume of the disease?
So we'll see how much response has been seen in post-chemo. Accordingly, we'll decrease the volume while contouring.
Dr. Jayant, can you tell about the ILROG guidelines on NKT cell lymphomas, the contouring guidelines?
Jayant, you're muted.
You're not audible, sir.
Jayant, you have to unmute.
I think Prarabdh is the best person. He's doing his thesis to tell the volumes. Prarabdh, you can reiterate the volumes again, the ILROG guidelines.
He did say actually.
Yeah,
you can say that again. Yeah.
You can retouch because it will be interesting for the residents also. Being a rare tumor, it's you can repeat
Anil,
that.
please let us know when we have to keep shut.
So we are good, sir.
Okay.
Prarabdh, can you tell that?
So regarding the ILROG guidelines, so again, sir, nasal cavity is confined to anterior and post middle part. We have to include the nasal cavity, hard palate, and if just one side of the maxillary sinus. If it's combined to the both left side of the nasal cavity, entire nasal cavity has to be included within the CTV volumes. And we have to include the whole of the maxillary sinus also in the contouring volume. if the disease has involved the whole of the nasal cavity. If the disease is involving the anterior model sinus, we have to include the posterior model sinus too, sir. That's what the ILROC guidelines is, sir.
So that's exactly what I was trying to highlight. The ILROC guidelines and the remaining guidelines, where they looked at the detrimental effect of reducing the volume, they found that the relapses are more. So Deepak made a very relevant comment saying that how would aggressive chemotherapy help you reduce the volume? Is that what you said, Deepak? So that would
the benefit of students, no, because whenever we give
Yes.
new adjuvant, there is always a
Yes.
doubt in the mind of students how to contour after it.
So exactly. So that is what the guidelines say, that you need to cover the maxilla and everything, even if they are not primarily involved. But what we have seen is we never do it. In our department, we never include. And our outcomes is there in front of you to see over the 10 years. But the only thing that we have done consistently over the last 10 years is that we have used SMILE chemotherapy, which is much more aggressive. And probably that is the reason we get away by not treating the maxilla. And that would reduce the volume that you need to treat. And that possibly would translate into a reduction in toxicity. So probably that's, but the pre-treatment disease, yes, that you have to include anyway. But the non-involved, here what they are recommending is that even if your sinus is not involved, you have to include it. Even if the maxilla is not involved, you have to include it. That is the recommendation. But we are not doing that.
The question was whether you're giving differential dose to the pre-chemo and boost to the gross disease after chemo, like that.
Possibly, yes. From the comments that Jayant made, so he told you what doses can be done with concurrent, what doses can be done if you have used chemo and radiation. So probably yes, but the gross disease and the high risk area needs to go to a higher dose than standard. So which would be 50 to 55. And the lowest that you can come with excellent response and good chemotherapy is probably 45. Yeah, not the current standard of 36 that you will see in the ILROC guidelines. And you'll get some information coming from Jayant also soon from our study, DOBL, although that is not NKT cell, but still.
So if I interrupt now, so we would like to conclude the session. Thank you, everyone. Over to you.
Thank you, ma'am.
Thank you very much.
Thank you, sir, again.
Thank you, Anil.
Thank you, everyone. We conclude our session, the last session for today. That was Hodgkin's lymphoma and best posters presentation. May I call upon Dr. Anil Tibdewal for a vote of thanks.
Yeah, so thank you, everyone. Mute. Yeah, so thank you, everyone. So we have completed our second.
Anil, you are not audible.
It's the time to Dr. Vyas, sir. So Dr. Vyas, can you hear us?
Dr. Vyas,
for you. Dr. Vyas is not with us. Then Dr. Sonali.
Yes, Anil. Yes, Anil.
Sir, if you have any comments.
Anil, it's a wonderful conference, and congratulations to you and Sonali for arranging such an academic feast. And all the presentations are very good and up to the mark. But one notice that other centers, they did not participate in fully. Only Sevagram, Aurangabad, one center in the Aurangabad, and TMH and my center. Actually, every time when we do the original conference rather than virtual meeting, everybody present. But this time, I think more representation should be there.
Sir, everybody does not have postgraduate students, and this time our focus was mainly on the postgraduate students. Probably that is one of the reasons.
No, Sonali, one DNP student can participate, na?
Sir, सब जगह नहीं है sir.
जहाँ भी है वहाँ तो होना चाहिए.
Sure, sir. We will do that in the next meeting. We would like to
but
invite and coordinate with them
congratulations
so
and
that
thanks
they have
for
the
your efforts. Sonali and Anil, we have done the wonderful job.
Sir, Sonali has not done anything. It's all Anil and Anuj who have done everything. So thank you so much, both of you, for all your efforts in putting this thing together at such a short notice. Anil, you're not audible. Your audio is off.
I'm sorry. So I would like to begin my vote of thanks by thanking Dr. Virendra Vyas and Dr. Sonali, who has given me an unconditional support for conducting this MSRI, and Dr. Umesh Manshetty. He is the secretary of the MSRI. He is not there currently in Maharashtra, but his heart will always be there in Mumbai, I know. And to the head of the department, Dr. J.P. Agarwal and Dr. Sarvani Ghosh-Laskar, for giving me this opportunity to organize the MSRI from the TMS department. And last but not the least, my colleague Dr. Anush Kumar, who is standing there. I want him to go there in front of my laptop and show his face without mask, because he is the man who was behind the scene for all. You must have seen all the emails and messages and WhatsApp in the nights, in the morning. He is the one who is to be blamed. So I would like everyone to give him a round of applause. And to my colleagues, Dr. Babusha, Dr. Prachi Sawant, and Dr. Sons Paul and Dr. Sahil Sood, who has coordinated these entire sessions of yesterday and today's. And I would like to thank my IT team support of the TMS, especially Mr. Sandeep Kalsekar, who has provided with us all the technical support, and all the chairpersons and speaker, and all the participants, because they have presented their data very efficiently and in a nice manner. I thought there would be slight hesitancy in their presentation, but they spoke like an expert. So they were answering all the questions, and they were very thorough in their presentation also. So let's hope to have next future meeting in person or in hybrid. But before we can conclude, I would like everyone to turn on their video so that we can take a screenshot. So I would request everyone, if they are in a comfortable position, to turn on the video. So
Anil, I pray that next year we will do the original conference rather than virtual.
Sure, sir.
We will enjoy. Though we met it through a computer, but I hope we will meet personally and will enjoy the whole conference.
Sure, sir. So please turn on the video, everyone. Dr. Arpit and Dr. Pradnya, if they are there, everyone, so that we can take the screenshot and we will share the screenshots. So this meeting will be available on the YouTube also, but we will share the YouTube link if anyone wants to see that.
Without mask, Anil?
Yes, sir. I'm without mask. Sahil is not.
I is Dr. Vyas not without mask.
Vyas sir, photo के लिए निकाल दीजिए mask.
Now, yeah.
Where will be the next conference?
And this is
we will decide in our next meeting, with our general body meeting.
Our WhatsApp group is very strong, MS, AROI, and TMS Elimini. So we will decide, and for the mutual convenient date and venue, we will do the conference.
Goa is pending, sir.
With me, more of the ceiling is visible.
Yes. So I'd like to thank everyone from the bottom of my heart. So with this, we would like to conclude our 2-day conference of the annual meeting of the MS chapter of AROI.
Photograph हो गया सोनाली?
अनिल हो गया कि नहीं?
Yes, ma'am. हो गया.
Okay, चलो.
Where is Dr. J.P.
Sir, mask पहन लीजिए.
Yes, ma'am.
We'll sign off now. Bye. Thank you so much, Anil.
Thank you, everyone.
Thanks a lot.
Bye.
Thanks a lot,
Bye,
everyone.
Anil.
Bye.
Job. Yeah. Bye. Video background.
Stop on the YouTube stream. Okay.